everyone. Welcome back to another day of our free NCLEX review sessions. And for those who are new to the channel, we are welcoming you as well. And we are on day 47 of the 90 days free review sessions with Stancoast, NCLEX-coaching.com. And for those who are in the classroom right now, we welcome you as well. Hello, everybody. I hope that you're doing well. And we are also encouraging everyone to enroll to our course, NCLEX course, at www.stancoast.NCLEX-coaching.com. We will be tackling a variety of nursing topics. And this time, with our free lectures, we are focusing on the medical surgical nursing concepts. And with your subscription to our program, you will be able to access that for the entire 6 months. And we also rated the amount of the hours in our on-demand videos, 20 hours of the animated videos for your flexible study, and also 200 hours of the recorded lectures. And this will be on top of the other resources we have. We have audiobooks, flip books, mock test exams, and also the 200 plus NGN test questions. And I'm sure this will also be increased in the number. And today we'll be talking about the concept on the different types of shock, and we'll also be dealing with some of the test questions here. We'll be doing some exercises, and so we are encouraging everyone to stay tuned and also make sure that you write down those important concepts in your notes so you will not forget those. Now, please don't forget to like and subscribe this video if you find this lecture discussion helpful, and also share this to your friends who are also preparing for the NCLEX. Hello, everyone. For those who are new to the channel, welcome, welcome, welcome. And we thank you for all those who have been coming in into the classrooms regularly. We really appreciate your attendance, so thank you again. So let's go right ahead with our discussion about the shock, and we're going to be talking about the different types as well. So we will focus about the shock itself, and this is basically a critical condition where the body is having an insufficient delivery of the oxygen. There's also insufficiency in the delivery of the nutrients to the body's organs and also the tissues. And with this insufficiency in the delivery of those substances, oxygen, nutrients, blood, then this can also alter the perfusion and also the cellular function. Well, what do you expect if the body is not getting the nutrition, the blood, the oxygen? It will not be able to function properly if it's deficient, if it's not getting those important elements. Now, this is a life-threatening process, and the person here will gravely have some changes in their hemodynamics. It will affect so many organs in the body. We can name so many, and we'll be talking a lot more of those. And the organ failure will happen whenever there is severe inadequate perfusion, which will then lead to that problem. And so it is very important for us to understand really the pathophysiology, the mechanisms, and also the differences between those types of shock, right? Yeah, I'm not quite sure with the audio. I don't know. Can you confirm, guys, if the audio is a problem this morning? I'm not quite sure, so let me know in the message. Now, we got to be careful, guys, that especially for the elderly population, most of our patients will be a lot older, maybe greater than 60 years old, maybe 70 years old. And so we definitely need to consider the age of our patient and also how well their systems will be able to compensate. So we need to do that. So for the elderly, what do we expect, especially in the older adults? Well, they are going to be very vulnerable in the shock because of the body-related changes, wherein they will have less ability to compensate for decreased tissue perfusion. It's breaking. Okay, let me take a look. Not sure what is going on. All right, let me try to move microphone. All right, give me a few seconds here to fix. What about this time? Can you hear me better? Hello? How's my audio right now? Can you hear my audio better this time? How about this time? Can you please confirm? Not quite sure what's going on. Why? Try to adjust the position. Okay, how about this time, guys? Can you hear me better? Okay, good. It's clear. Wonderful. Let's proceed. We're talking about the implications on the care, especially for the elderly patients. Let me move quite closer to my mouth. But again, the vibration, I think I'm just a bit loud with my voice today. Okay, maybe this one will work better. Okie dokie. Now, for the implications in the care of our elderly patients, especially if they have the shock, again, they are known to have reduced compensatory mechanisms. Of course, with the aging process, they will not be able to respond as effective as with a normal person, right? They're not gonna be able to compensate readily to the changes inside their body. And of course, if they're trying to attempt the homeostasis, or let's say the blood supply to the organs, it seems like they're gonna not be able to compensate in a much more of they don't respond better as far as maintaining that homeostasis, I should say. Now, in the elderly people, there is also progression of the shock in the stages, right? They're gonna progress into the levels of shock from stage 1, 2, 3, and 4. And again, the reason for that is the decreased compensatory mechanism in their body. And it is very important for us to really intervene and diagnose these elderly people as early as we can. We have to make sure that our assessment is timely, and we want to make sure that we're going to notify the healthcare team and also the medical provider in order that we can treat this patient in a timely manner and to prevent any more complication. Now, in the elderly, there is a problem with the baroreceptors, right? There is decreased function of the sensors in the blood vessels, and these baroreceptors are intended to detect the different changes in the blood pressure. And so again, there is decreased detection in the body changes. They will not be able to determine what is really going on. So their response is somewhat slowed this time. And of course, with the decreased baroreceptor response, this will not be able to signal the catecholamines. Remember those epinephrine, norepinephrine, they will not be able to be released. They're not going to be able to release those catecholamines as easily as a normal person can because of the decreased detection by the baroreceptors. Now, this can also impair the heart's response, guys. It can decrease the pumping mechanism, the contractility of the heart, and also it can delay the vasoconstriction. Okay, so let's talk about that. There is going to be what? Decreased pumping ability of the heart. And also there's going to be delayed response, especially to vasoconstriction. Delayed vasoconstriction. All right. And along with that, because of the decreased pumping ability of the heart, what do you think about the cardiac output this time? The blood pressure. Well, of course, it is going to be low cardiac output, and same thing with the blood pressure. All right. So all the more the body will be deprived of all the oxygen, the blood, the nutrients, and this can really worsen the organ function and it will cause multi-organ failure. Now here, guys, we're going to need to know the different stages of shock, the different varieties as well, so we can tailor our care plan of our patient. Okay, we are going to customize the care plan according to the severity and according to the type of shock that they have. Now this time, guys, we're going to have to talk about the different types of shock. So I am hoping that you already are quite familiar with these. We're just going to have to review those important stuff, or maybe you're going to learn something new today. So that is my goal, that we'll be able to have more enlightenment today. Now let's start with the cardiogenic shock. And as you notice, guys, I divided my screen into the output type of shock and the volume type of shock. Okay, we will understand why there's a need for us to do this. Okay, alrighty. Now, what is a cardiogenic shock? Well, basically, the cardiogenic shock is part of the decreased cardiac output. Same thing with obstructive type of shock. These two belong to this classification as output type of shock, meaning the two types here, the cardiogenic and the obstructive type, will lead to a decrease in the cardiac output. And the reason for that is because the heart will not be able to effectively pump the blood from the chamber, and it will not be able to supply enough blood to the circulation. Now, the cardiogenic shock is going to happen. It's because maybe the person had a recent heart attack, especially if it's affecting the anterior portion of the heart or the ventricles. Or let's say when the person has a myocardial infarction or heart failure, maybe they have an issue with cardiomyopathy, wherein there is a problem with the pumping mechanism. The heart muscle is not able to effectively pump the blood out from the chambers. Now, if there is also a problem with the heart rhythms, maybe a person may have a conduction system disorders, maybe they have heart blocks, maybe they have atrial fibrillation, or maybe premature ventricular contractions, or those other electrical abnormalities, then this can lead to the poor pumping mechanism of the heart. Okay, so I'm including everything, all those stuff that is inclusive about the low cardiac output. Now, here we're going to talk about the next one, which is the obstructive shock. What is this? And I mentioned this way back when we were talking about the pulmonary embolism, which is basically the formation of the clot in the blood vessel, and it can possibly migrate into the pulmonary circulation, and it can lodge into one of the great vessels, maybe the big pulmonary artery, or maybe a capillary or arteriole. And remember that this can really alter the blood flow into the peripheral or the small blood vessels in the lungs, right? And so it can create that dead space. There will be rerouting of the blood. And if there is such a case wherein there is a massive pulmonary embolism, it can lead to backflow of the circulation from the lungs. It can cause a high pressure in the pulmonary artery, which can lead to an increased pressure also in that circulation and can overwhelm the right side of the heart. And this can lead to the right-sided heart failure. Okay? And so the obstructive type of shock is going to happen when something outside the heart physically blocks the blood flow. That's why it's called obstructive. There is what? A blockage in the circulation, especially the pulmonary circulation. Blockage. In a case of pulmonary embolism. Now, what are the examples of the obstructive? You're present, Melrose. Welcome, everybody. For those who just came in, welcome back. Thank you for coming back. All right, so here we have the different examples of our obstructive type of shock. We have the pulmonary hypertension, and we talked about this before, right? Sorry about the sizes here. Also, the pulmonary embolism. Remember about the pulmonary hypertension? This can lead to the decreased cardiac output because the pulmonary hypertension can complicate into the right-sided heart failure. The same thing with a massive pulmonary embolism. It can also lead to right-sided heart failure. And it can also affect the cardiac output. All right? There will be a lot less amount of blood that will be oxygenated by the lungs because the heart, the right side of the heart, is poorly pumping or poorly forwarding the blood for oxygenation. Please, how much? What do you mean by please, how much? I want to know what that question is. I want you to be specific when you're asking the question so I can answer them accurately as well. Please, thank you. Now, another thing that we need to know about the other examples, there could be caused by the narrowing of the artery, or let's say it could be caused by a intrinsic mechanical compression, maybe caused by the tension pneumothorax. Let me erase this section right here. All right, so other causes for the obstructive shock will be the following. We have tension pneumothorax. Remember about that abnormal presence of the sudden appearance of that air coming from just out of nowhere, maybe an injury, maybe from a blip that burst. Okay, so it can lead to that tension pneumothorax. And once we have this problem, once the air is going to compress the lungs, it can also compress the heart, which will be causing it to reduce its cardiac output. Okay, there is compression of the heart, also the compression of the lungs itself, and there is what we call as the compression of the vena cava. Remember this when we talked about the tension pneumothorax, also the hemothorax. Because of the abnormal presence of the fluid or the air, it can push these important structures. The heart, it can also compress the vena cava. And so it can lead to a decrease in the cardiac output as well. Not clear. What do you mean by not clear? Is my voice not clear or what's going on? Can you let me know, please? All right, trying to position my filter. I hope that you can hear me this time. All right, now let's talk about the volume. Well, the types of shock that will belong into the volume classification. There is an impairment in the circulating amount of the blood, or let's say the fluid in the bloodstream. That's why the hypovolemic and the distributive shock will be classified according to the volume. Okay, when we are talking about the hypovolemia, we are talking about the loss or the lack of the circulation or circulating fluid volume in the bloodstream. Maybe there is blood loss, or maybe because of dehydration or excessive diuresis. Okay, now we're going to also have to talk about the distributive, which is basically a shifting of the fluids. If there is going to be, let's say, sepsis, it can lead to shifting of fluids from the intravascular compartment into the interstitial spaces. So there is now leaking of those fluids that are not supposed to leak in a normal condition. So let's talk about the hypovolemic shock. This is going to be caused by those conditions, like a drop in the intravascular fluid volume. Let me delete that. And the significant decrease is about 15 to 30%. Okay, a drop in the circulating fluid volume fluids, could be the blood, about 15 to 30% of a reduction is already considered as hypovolemic shock. Please take note of that. And this can be caused specifically by the following issues: the dehydration, the blood loss, and also the burns. All right, so these are the possible causes of the hypovolemic shock. I repeat, dehydration. It could be caused by urination, excessive urination, diuresis, vomiting, diarrhea. Blood loss could be caused by bleeding after a surgical procedure, maybe trauma. Bleeding may be caused by the gynecologic or obstetric causes, maybe placenta previa, abruptio placenta, or cases like burns, wherein there is going to be leaking of the fluids because of the loss of the first and second layers. Of course, the layers of the skin are already lost. And so this can promote leakage of those bodily fluids. Okay. Now, diabetic ketoacidosis can also lead to fluid volume loss, the DKA, and also the hyperosmolar hyperglycemic syndrome. Remember about that type 2 diabetes complication wherein the person will end up losing a lot of fluid, so they can end up with the hypovolemic shock. Now, talking about the distributive type of shock here, what is this? It is going to be caused by the widespread vasodilation. Take note of this word right here. In distributive shock, there is widespread vasodilation and also increase in the capillary permeability. Okay, take note about the vasodilation, increased capillary permeability. If you're not quite clear what that means, capillary permeability is increased. So, if there is such thing as increased capillary permeability, it can lead to what? Leakage of the fluids from the intravascular compartment. The increased capillary permeability actually simply means that the blood vessel wall is getting maybe thinner, or maybe now this time it's allowing those fluids to leak from the intravascular compartment into the interstitial spaces. So there is going to be fluid loss into the interstitial spaces. All right, so take note about the increased capillary permeability. Mary said, what about diabetes insipidus? Yes, of course. This can lead to the hypovolemic shock. If not treated, the person is actually going to lose about 10 liters at least of fluid in a day. Imagine that. You're losing 10 liters. That's more than severe. I mean, in a person with diuresis, maybe you're taking like a Lasix or something. It is expected that you'll be producing maybe 4 or 5 liters after you get that drug. But with the diabetes insipidus, the diuresis is superimposed. There is no antidiuretic hormone that will be able to reabsorb the fluids in the kidneys. And so the body will be losing a lot of fluid through the urine. Now, again, remember about this one. Distributive shock, there is going to be widespread vasodilation. There's also increased capillary permeability. So what do you expect if there is vasodilation? Of course, the blood pressure will be lower. Hypotension. I'm not just saying about 95/50. No. When the patient will go into sepsis, the trend of their blood pressure will somehow go downhill until it gets to its lowest point. Okay, so there's going to be significant hypotension in this patient. Now let's talk about the septic shock, which is basically under this classification. So we have the different shocks here under distributive shock. So one is septic shock, another is the anaphylactic shock, and the last one is the neurogenic shock. Again, they are under distributive shock. And why they are referred to as Distributive shock, well, remember about the shifting of the fluid. Instead, that the fluids stay in the bloodstream in a given amount of time. But here, with the onset of the infection, or let's say because of the anaphylaxis, or let's say the neurogenic shock, this will allow the fluid to leak into the blood vessels, or will leak out from the blood vessels, and they're gonna congregate in the interstitial spaces and will lead to low blood pressure. Now, guys, let's talk about the anaphylaxis. Oh, before we go to do that, the septic shock is usually common seen in patients with gram-neg bacteria. Gram-negative bacteria. And again, for those patients that are admitted in the hospital, let's say a regular urinary tract infection, which I had an experience with, older lady that came in because of nephrolithiasis with a renal infection. Yeah, she was supposed to have a kidney stone removal, lithotripsy, the next day. But when I was taking care of her overnight, her blood pressure started to go downhill. And so I started giving her boluses. After notified medical provider, sent her to ICU. The procedure was postponed because she needs to be stabilized first before she can get the stones out as well. And yeah, that was a good call. Simply watching the patients change in their blood pressure and the heart rate. Now, talking about the anaphylactic shock, what is this? Well, as we know that anaphylaxis can result from a severe allergic reaction, right? It could be caused by exposure to foods, maybe ingestion of any allergens, or it could be exposure to medications, and then they have a severe or sudden reaction to that substance. And so what's going to happen here, there is going to be severe widening of the blood vessels. Again, there is going to be widespread vasodilation. There's also increased capillary permeability. Okay. Now, guys, you may be asked in the NCLEX about the usual allergens that might lead to anaphylaxis. One of these items are the following. Let's say peanuts, latex. These are common allergens. Bee stings. And some of these patients can possibly lead to or can experience anaphylaxis. No kidding. In some medications, let's say ACE inhibitors, yeah, it can also lead to anaphylaxis. For some, maybe antibiotics, this can also lead to anaphylaxis. Now let's talk about the neurogenic shock. What is this? Well, when the person has this condition, when they have the neurogenic shock, this is going to occur because of the loss of the sympathetic nerve activity, okay? Loss of sympathetic nerve activity. So what is going to happen here? This can also cause blood vessel widening, massive vasodilation, and it can happen after a head trauma, or let's say when they have a spinal cord injury, or maybe they had a bad reaction to the anesthesia. Okay, let me write this out here. Neurogenic shock can be caused by a head trauma, or it could be spinal cord injury, or maybe as an adverse reaction to the anesthesia. Again, the patient here will end up with massive vasodilation, severe hypotension, and also the increased capillary permeability. Yeah, it said 45 watching, but only 17 likes. I think we can do better by liking the teaching. Well, thank you, Buzzbait. Yeah, that's true, right? So if you're a regular attendee and you haven't liked yet, I don't know. What's the issue? All right, I hope that you're going to like eventually, but I am encouraging you to like and subscribe if you haven't yet. Let's talk about the different stages of the shock. All right, so all of those different types of shock can be it can go through the different stages. So let's talk about the stage 1. What is in stage 1? This is basically the initial stage. So what is going on in the first stage? Well, the body will begin to switch from using the oxygen efficiently from aerobic metabolism into a less efficient anaerobic metabolism. And the reason for that is because of the decreased oxygen delivery. Decreased oxygen delivery. Okay? Take note of that. The body will switch from aerobic to anaerobic metabolism. And the reason? Because of what? Decreased blood pressure. If there is a decrease in the blood pressure, what do you expect in the perfusion? There is also decreased tissue perfusion. And that simply means that the body cells will be deprived of the oxygen, the nutrients. And so the cells will start to do its own work by, yeah, let's just keep working right now, even though we don't have the oxygen. And this is what we call as anaerobic metabolism. It can cause an elevation of the lactic acid. All right. And so here we have a reference value for the lactic acid. For the venous lactic acid, it's 0.5 to 2.2 milliequivalents per liter or milliosmoles. Arterial lactic acid is 0.5 to 1.6 milliequivalents or milliosmoles. And so it is expected that, in some textbooks, it will have this kind of range. In some textbooks, it will say 2 milliosmoles per liter. And so anything beyond that value, it's already considered as lactic acidosis. All right, so I just want you to keep in mind here, this is just our different levels of the lactic acid in a venous or arterial blood sample. Okay, and for you to be safe, especially in taking the NCLEX, I would consider anything above 2 as a sign of lactic acidosis. All right, I'm just giving you the different references here from my resources, but mostly the NCLEX will rely on the level that is greater than 2, that is already considered as lactic acidosis. All right, greater than 2. Don't forget that. Now, what are the manifestations in the patient? Well, there is going to be there are going to be changes that can be seen in our patient. There will be an increase in the heart rate, the respiratory rate, and also the diastolic blood pressure. So this is going to occur during the initial stage. Subtle changes, slight increases in the heart rate, slight increase in the respiratory rate, and a slight increase in the diastolic blood pressure. Please take note, I'm talking about the diastolic pressure. This is a normal compensatory mechanism of the body in response to that first stage of shock. Okay? You might also find in a scenario, maybe they're gonna put a restlessness as one of the symptoms. Yeah, let's put it right there. Restlessness is another early sign. Or they might call it as listlessness. They're quite similar, all right? Restlessness or listlessness. Now, talking about the mean arterial pressure, what is this? The mean arterial pressure basically is the measurement that will be considerably decreased when there is sepsis, or let's say when there is shock. Okay, not just sepsis, but also in the different types of shock. You don't make like voice notes? Do you want me to make voice notes? If I have 17 days or 14 days a week, I probably would gladly do that. But no, my time is limited. And so I really like to do so many things to make more educational materials. But with my time, it's quite limited. I'm sorry, I just can't. we're talking about the MAP, the mean arterial pressure. This is going to be decreased, and the significant decrease here is less than 10 mmHg, okay? MAP. Now, again, the MAP is our indication that maybe the body is still perfusing well the vital organs. So if the MAP is within that safe range, let's say MAP normal range of 70, or let's say greater than 70, this is considered as safe MAP. This simply means that the body is still able to perfuse, it's still able to supply blood, supply oxygen to the body tissues, okay? Again, the mean arterial pressure will be a determinant that the heart, the body is able to perfuse oxygen, blood, nutrients to the body cells. And so we are supposed to expect a normal MAP if it is greater than, or let's say equal or greater than 70 mmHg. However, if there is going to be a drop less than, or a drop of 10 points, maybe 60, that is already a significant amount of MAP reduction. So maybe that person will have 60 mmHg or maybe lesser. That signifies that the body is no longer able to perfuse blood to the organs, okay? There is a reduction in oxygenation, reduction of blood supply because of the vasodilation, decreased blood pressure, decreased cardiac output. And so there is now going to be so many changes, all right? The kidneys will now start, hey, what happened to my blood supply this time? What should I do? So the body organs will start to get confused. What is going on? I cannot function really well without enough blood supply, no oxygen. So our organs will start to do the weird stuff. They're not going to be able to function as normal like before. And so what are we going to expect here in a case of different types of shock? There's going to be so many changes. Like I've said, those vital signs, don't forget about the heart rate increase, the respiratory increase, the elevation of the diastolic blood pressure in the early stage, and also the listlessness or restlessness. And then there is also elevation of the lactic acid. Please take note, those are the early signs or lab results in the first stage of shock. Now let's talk about the second stage, which is the compensatory, or known as the non-progressive stage. Okay, so what is this compensatory? Well, here the body will now activate the compensatory mechanisms in order that it can maintain the blood flow to the vital organs. Okay, so one of the compensatory mechanisms here will be the stimulation of the sympathetic nervous system. Please take note, in stage 2, the SNS will be activated, and this is going to cause the release of those catecholamines. So I don't know if I have here. Yes, it can increase the release of the catecholamines, the epinephrine, norepinephrine. And so what do you expect if there is going to be the release of the epinephrine, norepinephrine? Well, you will see that the heart rate this time will be much more elevated. Okay, the contractility of the heart muscle will also be strengthened. Increasing contractility, there's also increasing heart rate, and this is way higher compared to the mild elevation here in the first stage. All right, and the reason for that is because the activation of the SNS, or the catecholamine release. Now, another event that can occur in the compensatory or non-progressive stage will be the neurohormonal response. So what is this? This can release that hormone aldosterone. Remember about the aldosterone, guys? This is a hormone that is released by the what? Adrenal, what? Medulla or cortex? Let me know if you still recall. But for the aldosterone, this is going to be released by the adrenal cortex. So what do you expect if the aldosterone will be released? This can lead to the reabsorption of sodium and water. Sodium plus water. There's going to be reabsorption and retention of the fluid and salt in the body. Okay, retention of sodium plus water. So that is the end effect of the release of the aldosterone. Now, what do you expect with others? Well, it can lead to an increasing heart rate as well because of the metabolic changes. Thank you for the answer. Cortex is the correct answer. And despite that, the body tried to compensate by stimulating the SNS or allowing this neurohormonal response. Well, the body will continue to decrease the MAP. So it will now further decrease in the MAP. There will be a reduction of about 10 to 15 mmHg reduction. So if there's already a reduction here in the initial stage, all the more there's going to be a 10 to 15 reduction of the MAP in the non-progressive stage. Again, the heart rate will elevate because of the SNS stimulation, and the glucose can also be increased because of the metabolic response. Take note of this, guys. There will be hyperglycemia because of the neurohormonal response and also the stimulation of the sympathetic nervous system. Okay, hyperglycemia. So don't forget about that. And that's actually one of the criteria in the diagnosis of sepsis, and we will be talking about that later. Now let's move on into the next stage, which is the progressive stage, stage 3. So what's going to happen here is that the mechanisms, the compensatory mechanisms that were activated in the second stage, they will start to fail this time. Again, the neurohormonal activation, the SNS activation will start to fail. And here, the body will now manifest so many electrolyte imbalances because of the disrupted cellular function. There will be electrolyte imbalance or imbalances and possibly acid-base imbalances because of lactic acidosis. Remember about the lactic acidosis? Yeah. The person will possibly complicate into metabolic acidosis and possibly respiratory acidosis as well because of an increasing buildup of carbon dioxide in the blood. And the patient will also manifest the peripheral edema. There's going to be buildup of fluid in the body tissues, some irregular heart rate, hypotension. And when your patient will go into this third stage, you will see the different color changes. They are going to be starting to manifest the paleness, or they're going to have that pallor. Their skin will be cool to touch. It will be clammy because of the poor circulation. And the patient here will have changes in their level of consciousness. So what are those changes, guys, in their LOC? Well, you will expect some confusion, restlessness. Maybe they're going to end up with drowsiness, lethargy, somnolence. You got to watch out because these are the telltale signs that the brain is no longer getting enough oxygen because of the hypotension and the decreased cardiac output. So if you have a scenario in the NCLEX, let's say, for example, the patient that you received from the ER was somewhat alert when she arrived into the nursing unit, but the next time you went into the patient's room, maybe 30 minutes or an hour later when you did your second rounds, maybe the patient is less alert. Maybe they're much more kind of like sleepy. And when you're trying to wake them up, they're not all there. They're not going to be able to tell you exactly the correct date and time. And so with all these different onset of changes, you get to suspect here that the patient has already a massive effect or a severe effect into their neural function because of the decreased oxygenation. All right. Now let's talk about the fourth stage, which is the refractory stage. So what is going on in this stage? Well, this is going to be the final and irreversible stage. And at this point, the body has already started to fail. There is going to be massive organ failure this time. There is already damage to the tissues, the organs, because of the severe lack of oxygen and blood flow. Take note of this. Irreversible cellular organ damage. So here our patient probably has end stage organ failure. Maybe 2 days ago their kidney function was still fine, but around this time their creatinine levels are skyrocketing, the blood urea nitrogen, the glomerular filtration rate, it's shutting down because of the organ damage. And the patient here will have this impending death. This can really progress so fast, guys. So I've dealt with so many patients with sepsis. Tell you, it's not a joke. Your shift will be chaotic as soon as you start detecting this. Yeah, you gotta have to be in your toes, and you gotta be sharp around this time to make sure that you're capturing all these manifestations. Now, let's talk about the disease prevention, and this is going to be a common question in the NCLEX. They usually would like to ask you if you're able to promote health to your patient before a problem can set in. They will ask you what could possibly be done for this patient before a complication can set in. So let's talk about the cardiogenic shock. What can you do for this patient before they can lead into shock? Well, so many things, right? For the cardiogenic shock, we can help them with educating about the risk of developing an MI. So those healthy lifestyle change, exercise, diet, stress reduction, smoking cessation are going to be the top priorities in the education, right? Now, for the obstructive type of shock, what can we do here? We're talking about education about wearing seat belts, helmets, especially to reduce the incidence of accidents, especially because here we're going to talking about trauma to the chest, right? Those flail chest, the hemothorax, pneumothorax can be caused by the injury, physical injury or trauma, such as when the person may encounter a vehicular accident. So that's going to be a specific topic that might come out. Or it could be the use of caution with dangerous equipment, machinery, or activity. So these are topics that might be asked as prevention, right? Now, another is about the prevention of hypovolemic shock. So what can you do for this patient? Well, if no restrictions, you can advise the patient to increase their fluid intake when they're exercising or when they're exposed in hot weather, and also make sure that they will seek early intervention if they are ill, or let's say when they encounter a trauma, or if let's say they are bleeding out, then they need to seek early intervention. Now, we also need to teach our patient this time about the different manifestations of dehydration, to identify those so that they can call their medical provider from home. Hey, I have these symptoms. What can you do for this one? Do I need to show at your clinic, or do I need to be hospitalized this time? And so signs and symptoms of dehydration, thirst, decreasing urine output, dizziness, these are important manifestations that you can teach to your patient to prevent hypovolemia. Now, about distributive shock, what can you do here? The education will be geared towards advising the patient on let's say, seeking early medical intervention. Let's say they have some infection going on, maybe evidenced by localized redness into the skin. Maybe they have a boil or a staphylococcal infection, MRSA. Yeah, this is very common, guys. Those nasty wound infections caused by MRSA can really lead to sepsis. And I've had encounters with this kind of infection causing sepsis as well. So make sure that they know about what to watch for, what symptoms. If there is localized redness, swelling, if there is drainage, or let's say if they have a dialysis catheter, or maybe they have a peritoneal catheter, we're going to teach them what to report if there is going to be an abnormal drainage, pus coming out from those insertion sites. Maybe they're going to manifest fever, burning sensation. We really need to teach those manifestations in order that they can report those to the medical provider. And if they need to complete antibiotic therapy, that's another big deal. They need to be compliant with the completion of the antibiotic therapy so that there's going to be less incidence of bacterial resistance. Now, talking about the anaphylaxis, of course, one of the teaching topics here will be about avoidance of the allergens, and also getting rid of those items in the household that are known to be allergenic, and also make sure that they have the epinephrine. For these people that have previous anaphylactic reactions, they usually will have epinephrine with them, okay? Because they know that when they're exposed to that certain allergen, they're going to develop the anaphylaxis. So most of the time, they're going to end up with wearing the medical alert or medical alert wristband, and also make sure that they are carrying their epinephrine pen with them at all times. Okay, so those are the topics that might be asked in the NCLEX about preventing these different types of shock. Now, let's talk about the management and the identification of those signs and symptoms. So let's talk about the cardiogenic shock. What are those clinical features that you will be seeing in this patient? Well, there's going to be cold, clammy extremities. I hate this when the patient would say, I feel cold. Oh boy, what's going on? I'm already in a heightened alert that time when they're going to state something about cold, clammy. Well, that simply means that there is already reduced blood flow to the skin. There is already inadequate cardiac output. Decreased CO, decreased tissue perfusion. This is a sign of your cardiogenic shock. Reduced blood flow can lead to cold, clammy skin. Why? Why there will be cold, clammy skin? Well, the body will sense like, hey, I'm not getting enough blood right now because of the poor cardiac output, right? The heart is no longer able to properly pump the ventricle to push the blood out into the systemic circulation, or let's say it's no longer effective in pumping the blood to allow these blood to get reperfused in the lungs again. And so the body will tend to recognize that, hey, I am sensing that we are running out of the blood supply. And so, hey, let's divert the blood supply to the more vital organs in the body. So it will now lessen the blood supply to the peripheries, okay? So the body will try to prioritize the blood flow to the body organs. Result of blood flow diversion. From the peripheral organs into the vital organs. There is diversion. So the body will just, hey, we'll just prioritize the blood right now into the main organs, the vital organs. And that is why our patient will end up with a cold, clammy skin because of that diversion. Now, another is the poor cap refill. We know that the excellent cap refill is less than 2 seconds, right? Yeah. In the cardiogenic shock, the capillary refill will be prolonged, okay? It simply means that there is now decreased blood circulation and also poor peripheral perfusion. Now let's talk about the elevation of the jugular venous pressure, distended neck veins. Why? There's going to be distension of the neck veins and elevation of the JVP, which is the jugular venous pressure. We'll remember about the cardiogenic shock. This is going to be caused by the MI and also the congestive heart failure. Remember about that? MI and heart failure, especially more likes on the main button, please. Okay, thank you. Right-sided heart failure. Remember about that. Whenever there is going to be a failure on the right side of the heart, let's say the left ventricle, it can cause overwhelming pressure into the lungs. And of course, if this can progress more problems inside the lungs, it can also lead to the right-sided heart failure. And so the patient here will have an increase in the pressure inside the venous circulation. So you will see the patient with the heart failure having the distended neck veins. Remember about that concept? I repeated this several times, and so I don't have to this time, all right? Make sure that you recall about the MI heart failure causing the decreased cardiac output because of the impairment in the ventricular function. Now let's talk about the chest pain. Why there is going to be chest pain in a patient with a cardiogenic shock. This is a result of the decreased oxygen blood supply to the heart muscle. Of course, the heart itself will need to be oxygenated as well. If there is a compromise, if there is a poor blood flow or poor cardiac output, then the blood flow to the coronary arteries and into the muscle tissue will also be reduced. And this is caused by that ischemia. Okay? Yeah, they're going to end up with chest pain because of the poor cardiac output and poor oxygenation. They're also going to manifest a palpitation, which is that bounding pulse in their chest. It's going to be irregular, and this is caused by the impaired cardiac function. And the syncope, which is another manifestation, the feeling of getting ready to faint because of the inadequate blood flow to the brain, low cardiac output as well. And if the patient has a pre-existing heart failure, they might have worsening of the heart murmur, and this is caused by the valvular dysfunction. I want you to take down notes, guys, because every type of shock actually has its distinct issue. And so you don't want to be confused here, guys. Make sure that you write down notes so you will not lose the basic knowledge. So the worsening murmur will occur because of a pre-existing valvular dysfunction and also the structural changes in the heart, especially the heart valves. And that is why you will hear those abnormal swooshing sound, maybe regurgitation can occur. Now, in a case of, let's say, heart failure, what do you expect? Well, you will see that the patient's central venous pressure will be elevated. Normally, our CVP ranges from about 8 to 12, and this is cm water. In some sources, it will be 5 to 10. But in most literatures, EBP studies, evidence-based practices, they are going to refer to the 8 to 12. So whatever is safe for you to use in the exam, do it. But I'll use the 8 to 12 cm water. So what is the CVP? Basically, when the CVP is increased, maybe greater than, let's say, 12 cm water, what do you think about that? It simply means that there is a high pressure in the large veins entering the heart muscle, okay? So especially with an increased CVP, what is it? It simply means that there is increasing pressure Or let's say there is congestion of fluid in the venous circulation. Congestion in venous circulation. However, if there is going to be a decrease in the CVP, let's say less than, I will just use 5 for now, less than 5 cm water, it would mean that there is going to be hypovolemia or maybe massive loss or diuresis. And so this can also predict that the patient really has an issue with the circulating fluid volume. They lack the fluid. Okay, so back to the cardiogenic shock. There will be increase in the CVP. Why? Remember about the inefficiency of the heart muscle in pumping blood? Remember about the heart failure. The ventricles will not be able to effectively pump the blood into the circulation. Or let's say the right side of the heart is having an issue in pumping the blood to the pulmonary circulation. So what's going to happen is that there is going to be backflow of the blood from the right chamber. The right chamber of the heart will be congested because of the problem specifically in the right ventricle of the right side of the heart failure. So again, this can cause the congestion of blood in the venous circulation. Of course, the jugular vein will also be seen getting engorged. All right, so that's going to lead to a increasing CVP. Now, what else are we going to expect in a case of cardiogenic shock? There's going to be, let me delete that, the person will end up with a decrease in the cardiac output. Of course, a cardiac output is the total amount of blood that will be ejected by the ventricles every minute, supposedly 4 to 6 liters per minute, but this is going to be decreased significantly. There's also a variable heart rate. So what is this variable heart rate? It basically will be affected. It could be high heart rate, tachycardia, or it could be bradycardia. So it kind of fluctuates. It's not consistent to be in the 80s, 70s. It kind of fluctuates just on every range. So this is caused by the decrease in the cardiac output as well. Now, talking about another is the SVO2. Have you heard of the SVO2? Decreased SVO2. So this simply means that the content of the oxygen in the venous oxygen is decreased. There is what? Decreased oxygen content in venous blood. So this is significant. All right. Now let's talk about the treatment, guys, for the cardiogenic shock. What are you going to expect here? Well, one of the treatments will include IV fluids according to the fluid responsiveness. But you got to be careful. You got to be cautious when you're administering the IV fluid, especially if the patient already has a heart failure. You gotta be careful, guys. You gotta be cautious, because if our patient is possibly having a fluid overload, then we don't want to add to that problem. So this is going to be done very cautiously. So the fluid bolus that you will be giving this time will be based on the patient's response. Okay, do not just give the bolus if you have not really investigated further. Okay, again, this is going to be very reserved. This is going to be reserved for those patients that really need resuscitation. But most often, we're not going to give the bolus for those patients with heart failure. Let's talk about inotropic support. So what is inotropic support? So if in a case wherein the person will end up with the cardiogenic shock, what do you expect in this kind of intervention? Well, we're going to have to administer possibly the dobutamine or the milrinone. So these are the medications that we know of that can improve the cardiac output. Okay, dobutamine and the milrinone. And of course, you're not going to expect to give this medication in the med-surg. These are medications that can be initiated in the critical care areas. And so your patient around this time probably has worsening cardiogenic shock. So you're not going to keep this patient in the med-surg. You're already shipping this patient out from the med-surg unit. But again, we're going to have to talk about the other stuff like critical care as well, because our care will comprise of any department in the hospital, right? And so the reason again for the use of the dobutamine and milrinone, it is going to what? Increase or improve the cardiac output to maintain circulation to the vital organs. Another medication group that we'll be expecting to administer will be the vasopressors. For example, we have the dopamine, the norepinephrine, norepinephrine. Okay, and this is going to maintain the adequate systemic vascular resistance as well, and will improve the blood pressure. All right, so don't forget inotropes, vasopressors. Don't forget that. Now let's talk about an intervention that can be tricky as well. Another medication that we probably would give to the patient is, or are the diuretics. Now, be cautious again. You're only going to administer diuretics for those patients that have what? Severe CHF with pulmonary edema, right? If there is a need to get rid of those excess fluids from the lungs, or let's say if there is congestion in the circulation, then we're going to have to administer the diuretic, especially the Lasix, which is the potent loop diuretic. All right, loop diuretic. Now, you're only going to give that if the systolic blood pressure is greater than 90 mmHg. If you check your patient's blood pressure and it's less than 90, do not give the diuretic. It will cause hypotension all the more. So hold the drug. Notify the medical provider. Hey, doctor, you ordered the Lasix for this patient with the cardiogenic shock. You ordered this because the patient has signs of pulmonary edema, but my patient's blood pressure right now is somewhat 88/40. What do you want to do? What will you recommend? So speak to the doctor or the medical provider that this medication that they're ordered probably will not be safe for this patient. So it is going to be dependent into the patient's overall state. If the patient's blood pressure is still above 90, go ahead and do that and monitor the patient's vital signs, okay? If the patient's systolic blood pressure is already low, do not give the Lasix. It will cause more issue in the cardiac output. Now let's talk about the treatment of refractory heart failure. So what is this all about? Well, we're going to treat the problem as it is. We're going to have to address the underlying condition. Maybe we're going to have to treat the coronary syndrome. Maybe it will include the treatment of the arrhythmias. So let me write that down. Treatment of arrhythmias. So if the patient has, let's say, AFib or the premature ventricular contractions, treat those. Those can be treated easily with medications, or let's say replacement of electrolytes is needed. Or we're going to have to treat the valvular dysfunction as well. So we need to identify really what's going on in this patient. Now moving on to the next type of the obstructive shock, which is the obstructive. But before we go to do that, again, we are inviting everyone to enroll to our program, the NCLEX Review Program. And I want you to visit our website at stancoast.NCLEX-coaching.com to know more about us, and also click the link below in the description box. We have upgraded all our available sources and also the services that we have. And so if you have any questions, stay tuned. If you want to stay over a little bit after the class, let me know. And so I can communicate this to my boss as well. All right. Now let's talk about the obstructive shock. What is going on here? Well, the patient will manifest many things. Again, there will be cold, clammy extremities. And the same reason is happening here. There is reduction of the peripheral blood flow because of that mechanical obstruction, maybe caused by the PE, right? Or let's say the pneumothorax, hemothorax, or maybe blunt injury to the chest. So the person here will have compromise in the cardiac output and blood pressure. Decreased CO, decreased BP, decreased oxygenation. Simple as that. Now, the patient will also have poor cap refill because of the decreased perfusion to the distal portions of the body. Again, there is rerouting of the blood supply. They want to supply more onto the vital organs. And so there is going to be poor cap refill. Now, talking about the jugular venous pressure, it will also be higher. There's also the JVD, right? Remember about the JVD in our case, such as the pulmonary arterial hypertension, the pulmonary embolism. There is backflow of the blood coming from the heart, coming from the respiratory system, from the lungs. It will increase the pressure in the pulmonary artery. It will increase the pressure inside the right ventricle. It will cause congestion to the right side of the heart and also congestion of blood into the venous system. And that is why there is going to be positive JVD and elevation of the jugular venous pressure. Now, because of the poor O2, poor cardiac output, poor blood supply to the heart itself, this can also lead to the chest pain, poor blood supply to the heart itself. There's going to be diminishing breath sounds, and the reason for that is because of the reduction in the airflow into the lungs because of the lung collapse. Why is the lung collapse happening? So if in a case of a pneumothorax, all right? Okay, so if this pneumothorax will increase in size, or let's say a hemothorax, accumulation of blood in the pleural space. If there is trauma to the chest, maybe the person met a vehicular accident, there is trauma to the lung tissue, the blood will pool into the pleural space. It can compress the lungs. It will not be able to inflate properly during inhalation. And so what do you expect? The patient's lung sound will be diminished, all right? And it can worsen. It can also cause the shifting of the mediastinum into one side, okay? Now let's talk about the tracheal deviation, which I just said here. This is the movement or the shifting of the trachea because of the pressure from a mediastinal mass, or it could be from a pneumothorax, or it could be the hemothorax. Now, let's talk about another manifestation, which is also considered as an obstructive type of shock, muffled heart sounds. Why is this going on? Have you heard of the case cardiac tamponade? Cardiac tamponade, which is the, let me rewrite that. The cardiac tamponade, which is the abnormal accumulation of fluid surrounding that heart. Cardiac tamponade. So the heart has that special sac, okay, covers the heart, and within that space there's that little volume of fluid there. This is the fluid that will lubricate the heart in order to prevent friction from the parietal and the visceral layers, right? And so it will allow lubrication to the heart from the other surfaces. So we have that fluid supposedly. However, if there is a cardiac tamponade, when there is excess fluid accumulation surrounding or in this space. So it will cause compression into the heart muscle. So it will not be able to pump harder because it's already occupying a good amount of space, just like in a case of a hemothorax. So when there is now increased fluid in the layer, in this space, pericardial space, it will prevent the heart from pumping effectively. And so this is going to lead into a decrease in the cardiac output as well. Okay. And when you are going to auscultate this patient, it will be sounding muffled. You will not hear the lub-dub type kind of sound. It will be sounding distant. All right. So when you encounter the word muffled sound, the heart sound will be distant. It's not as crisp when you are listening using that stethoscope. All right. Muffled is distant heart sound. So you will not really hear the regular lub-dub, lub-dub, lub-dub. No. And this is also a medical emergency that will require drainage of that excessive fluids. Now, another manifestation here in the obstructive type of shock will be features of DVT, wherein the person will end up with swelling on the leg. There will be warmth, pain on the affected limb. And this is caused by the clot, right? Yeah, of course, clot formation. Clot blockage. Now let's talk about the decreased cardiac output. Why? Well, with the mechanical obstruction, or let's say compression of the cardiac chambers, or let's say the blood vessels, the heart itself will no longer be able to produce that adequate amount of blood from the heart into the systemic circulation. There's also increase in the central venous pressure because of the what? Congestion of blood in the venous circulation. And the heart rate will also be increased, and this is caused by the compensation due to the poor blood supply. The heart will be forced to work harder in order to produce blood, but it's not going to work. Okay, it will just fail. It's just a rapid heart rate, but it's not carrying enough blood to supply into the body. Now, another manifestation here is the decrease in the saturation of oxygen in the venous blood. Because of the poor oxygenation, you will see that the value will also be decreased. So what are we going to do here to treat this patient? So basically, this is a picture of that patient with a CVP, right? Again, the CVP will be increased greater than 12 cm water in this patient because of the venous congestion. Now, what are we going to do to treat the obstructive shock? Well, remember about the muffled heart sound, especially in the cardiac tamponade. That excess fluid in that layer or that space in the heart. Remember that it can prevent the heart from pumping effectively. And so the procedure to treat that is the pericardiocentesis. Okay, so this is going to remove the excess fluid, or actually the blood that's squeezing the heart. So there's going to be an insertion of a small needle in order to drain the fluid out. And by reducing the fluid, it can give much more room for the heart to effectively pump. And so this time, once the procedure has been completed, there's going to be an extreme relief from that drowning kind of sensation. Now, another procedure that can be done, especially if the case is on a hemothorax, or let's say pneumothorax. So if there is a huge, or there's an increased volume of blood accumulating in the pleural space, well, the doctor can do the thoracostomy, right? And they can also do that needle thoracostomy and followed by tube thoracostomy. So there's going to be insertion of that catheter to drain the blood or the fluid, or maybe an insertion into the upper portion of the lungs to drain or to remove excess air. Remove pneumothorax, or here, remove hemothorax. Take note of those. So once the patient will have, if the patient will have successful treatment, or let's say, for example, days later on, there's going to be much lesser volume accumulating in the pleural space, then this time probably the lungs will now start to re-expand. So it can help in the oxygenation process. Now this time we're going to have to talk about the treatment of the blood clots, especially in the case of pulmonary embolism. Remember that pulmonary embolism is actually part of the obstructive shock. Yeah, we can treat the patient with the use of those clot busters to lyse those big blood clots in the pulmonary artery. So to prevent damage and also to treat the right-sided heart failure. What else? We're going to have to treat the other types of shock here. So let's move forward into the hypovolemic shock. And this is very common, guys. I'm sure that you are very good with identifying the manifestations of the hypovolemia. So let's just run through here. There's going to be what? The hypovolemic shock is caused by the blood loss, extreme blood loss, or maybe diuresis caused by the medications, or maybe conditions like diabetes insipidus, right? And maybe burns, or hemorrhage, or dehydration, or diarrhea, or excessive vomiting. This can lead to the hypovolemia. So the patient here will manifest pretty much the same set of symptoms like cold, clammy extremities. And this is again caused by the decreasing circulating fluid volume. Slow cap refill is another one. And the same reason, reduced perfusion to the distal part of the body because the body is trying to preserve blood circulation into the most important body organs. Now, we're going to talk about the non-distended jugular veins. Why? The patient here will have a non-distended. So this time, it's the exact opposite. You will not see the JVD. Why? Because the body is deficient of fluid. There's nothing really to cause congestion in the venous circulation. So this is what we refer to as empty heart. The body is actually depleted of the blood, depleted of the volume. And so there's nothing to congest the jugular vein. Now let's talk about the decreasing skin turgor. Remember about the dehydration here can also affect the integumentary system. The mucous membranes will be dry when you're going to expect that. Looking into the oral cavity, or it could be that the patient may have signs of GI bleeding. For those patients that may have some hemorrhage in the GI tract, maybe they have a perforated ulcer. Oh, wonderful. That's my favorite patient. If they have massive bleeding in their GI tract, or could be diarrhea, yeah, they can end up way too rapidly in the shock. Decreased urine output. What is this? Remember that the kidneys require how much? It requires 20% of the total cardiac output. So if we are supposed to have 5 liters per minute, and if there is a drop in the cardiac output because of the hemorrhage, or let's say the dehydration, so imagine if there's only 3 liters per minute pumped by the ventricle. What's the cardiac output? I mean, what's the percentage? It's gravely diminished. So this can impair the kidney function, and the patient will manifest oliguria. Remember about this? The patient will end up with oliguria less than 30 mLs per hour. Okay. Or let's say in a day, it's less than 400 mLs in 24 hours. Decreasing cardiac output. Now let's move forward here with the decreased cardiac output. Yeah, I don't have to explain that again. It's very common also in the hypovolemia. There is decreased CVP because the patient doesn't have enough blood circulating. So it will be less than 5 cm water, or less than 8. Okay. Now, what else? We're going to expect that the patient will also have increasing heart rate as a compensatory mechanism to the decreased circulating volume, and the oxygen in the mixed blood or the venous circulation will also drop. Now, guys, let's talk about the treatment. What do you think can be used for the management? Well, if there is going to be hypovolemia, we're going to administer fluids, right? Fluid resuscitation is one of the top management for this patient. So what you're going to expect here will be the administration of IV fluid boluses. Liters and liters of normal saline, or let's say lactated Ringer solution, in order to restore the circulating fluid volume. Fluid resuscitation, please don't forget that. What else? We're going to have to anticipate giving blood transfusion only if the issue is on bleeding. Okay? Of course, we're not going to give blood transfusions for those patients with normal hemoglobin or they don't have any signs of anemia. No, we're not. This is only intended for those patients with signs of bleeding or a significant drop in their hemoglobin level. What else? We're going to have to do the hemostatic control. What does that pertain? Well, if the patient is bleeding still, we're going to have to control the bleeding, possibly by sending the patient to the OR for surgical intervention. We're going to send them to the OR. Or possibly a removal of an emboli or any other type of hemostatic measures that will be able to prevent the blood loss. Okay, surgical intervention is going to be used to manage the bleeding. And of course, this can lead to the stabilization of the patient's hemodynamics. It can lead to the improvement of the circulation, the tissue perfusion, and also it can restore organ function. Again, these are your signs. If you don't know your signs, you will not be able to treat your patient. So go back to the assessment findings. Let's move forward here to the next type of shock, which is my favorite, distributive shock. And the very common type of shock here is the septic shock. It is a severe condition wherein the body has the infection that led into systemic inflammation. Okay? Systemic inflammation. So again, this is caused by an infection. For example, if the patient has been probably catheterized with poor aseptic technique, it can cause ascending infection into the urinary tract, or maybe poor exercise of the sterility technique during the dressing changes of the central line. What else? Maybe contamination of the IV fluid line. If you're not careful about managing those tubings, if you're not disinfecting the rubber stopper of the vial before you're going to poke your needle into that medication vial, yes, that can be a source of infection to your patient. So be careful when you are treating your patient here. So sepsis really is going to cause a cascade of those changes. And so what are you going to expect in a patient with sepsis? There's going to be an elevation of the temperature, and this is going to be above 100.9 degrees Fahrenheit or above 38.3 degrees Celsius. Or maybe the patient will exactly have the opposite, which is hypothermia. So guys, don't forget, one of the criteria in diagnosing the septic shock, it's either elevation of the temperature or maybe hypothermia, less than 97 degrees Fahrenheit or less than 36 degrees Celsius. Yeah, kind of weird, huh? But extremes of temperatures here, elevation, extreme elevation, or let's say low temperature, are signs of the septic shock. Why? Well, of course, with the inflammatory responses in the body is really trying hard to fight off the infection. So there's going to be extreme in the temperature reading. What else? The heart rate will be what? Elevated. So this is another criteria in the diagnosis of septic shock. Heart rate will be above 90 beats per minute. We know, right, that our regular range or normal range of the adult heart rate is somewhere between 60 to 100. Anything above is tachycardia. But here, the new criteria for the sepsis actually includes heart rate above 90 beats per minute. And that is just one of those criteria, okay? Now, another is tachypnea, an elevation of the respiratory rate above 22 cycles per minute is an indication that the patient might have sepsis as well. What else? Systolic blood pressure less than or equal to 100 mmHg, or let's say arterial hypotension. Let's say systolic blood pressure less than 90 can also be a criterion for diagnosing sepsis. What else? Yeah, it's getting more and more. When I was still at the bedside dealing with patients, we have this 10 criteria. Now there's more criteria. Now the MAP, anything that is less than 70 mmHg, or let's say a decrease in the SBP of more than 40. If there is going to be a drastic drop in the systolic blood pressure, let's say blood pressure of 130 and it went down to probably 90 or let's say 80, that's quite a significant drop, guys. So here you will think of, hey, my patient probably has the early signs of the sepsis. There's going to be altered mental state because of the poor circulation to the brain, decreased blood supply. Your patient will have confusion, might be drowsy, they might be lethargic, somnolent, and the reason for that is decreased blood flow to the brain. What else? The patient will have edema as well, positive fluid balance. Why? Well, because of the fluid shifting from the capillaries. Remember about the distributive, remember about this, that there is vasodilation and also increased capillary permeability, where it will allow the fluids to leak from the blood vessels into the interstitial spaces. And so there are going to be presence of edema, or what we call as positive fluid balance. And this is caused by increased capillary permeability. That's a bad sign, guys. What else? We're going to encounter some elevation of the blood sugar, which I'll discuss in a minute. But because of the poor blood supply to the kidneys, remember about the 20% requirement by the kidneys. If there is a decrease in the cardiac output, there's also decrease in the urine output. It simply means that the kidneys are not receiving adequate fluid volume. So they're going to end up with less than 30 cc mLs per hour output. What else? The patient will also have ileus or absent bowel sound. Not hypoactive, but absent bowel sound. When you're auscultating the patient's tummy, you will no longer hear those tinkling sounds, about 5 to 15 tinkling sounds, no more. If there is ileus, there is absence. It sounds so quiet in the stomach when you're auscultating. All right. Another criteria here is decrease in the capillary fill or mottling of the skin, the discoloration of the tissue, especially in the legs, distal part of the body. There will be somewhat kind of like purplish, bluish discoloration, and this is a sign of decreased oxygen to those skin. There's more, guys. Let's talk about laboratory findings in the sepsis, which is another criteria. Okay, we have hyperglycemia. Why? Remember about that SNS stimulation that we spoke earlier? When there is a drop in the blood pressure. It will lead to the stimulation of the sympathetic nervous system. Remember about that. It can cause breakdown of glucose stored in the liver, and it will be converted. So there's going to be hyperglycemia. What else? Leukocytosis, or elevation of the white blood cell. But guys, take note. It can be either leukocytosis or leukopenia. All right? Please take note, not only leukocytosis, but also leukopenia. So this is basically reflecting the body's response to the infection. So for a patient that may have the neutropenia in a case of, what do you call this? The leukemia, right? That we spoke about in the last few days. Remember about its effect into the bone marrow. It's no longer able to produce the mature blood cells, especially in ALL. So there's going to be reduction of the count. Or let's say infection, there's going to be elevation of the white blood cells. So it can be either leukocytosis or leukopenia. Now, another diagnostic test is, yes, this one, normal white blood cell count with more than 10% immature bands. Okay, that's another criteria or criterion. Another is C-reactive protein, which is going to be elevated, and this is a sign of inflammation. Widespread inflammation in the body. The C-reactive protein will be increased. What else? Another testing called procalcitonin. What is procalcitonin? Normally, the value here is less than 0.05 nanograms per ml. What can the procalcitonin indicate if there is elevation? Well, this is going to be elevated in a case of bacterial infection. Elevated in bacterial infection. So this will really distinguish if the patient may have a viral type of infection or a bacterial type. So the procalcitonin will be able to rule out any viral infection. Now, the patient will also have an increase in the serum creatinine. Remember that the kidneys will have that 20% requirement of the total cardiac output. And so if it's going to not receive any of that sufficient blood amount, then it will start to fail with elevation of the creatinine. Okay? There is now less excretion of the byproducts of protein metabolism, which is the creatinine. So it will start to build up. Now let's talk about the coagulation studies. Yeah. The prothrombin time, or the INR, I should say. Let me remove that one. The INR will be elevated, greater than 1.5, or the PTT will be greater than 60 seconds. This simply means that our patient probably is leading into the DIC, disseminated intravascular coagulation. And this is a common complication in sepsis. Right? Elevation of the PTT, elevation of the INR, and on top of that, the patient will have thrombocytopenia, less than 100,000 per cubic millimeter. And the patient will also have an increase in the bilirubin. The total bilirubin will be greater than 4 milligrams per deciliter. Okay, that simply means that the patient is also developing the DIC. Now, other stuff, there's more, guys. The lactic acid will be above 2 milliosmoles per liter. Remember this. Lactic acid will be greater than 2 milliosmoles per liter. It simply means that the cell is working hard to do its metabolic processes without oxygen, the absence of oxygen. Again, recall the anaerobic metabolism. And so this can lead to the metabolic acidosis. That's quite lengthy, right? Yeah, it's overwhelming. And that's the nature about the disease. That's why we need to know about these things. Now, how are we going to treat this patient with the sepsis? How are we going to do this treatment? Well, fluid resuscitation is our priority. We're going to have to administer patient isotonic crystalloids. IV boluses. We're going to have to give the crystalloids normal saline, lactate ringer solution in order to rapidly restore the intravascular volume, right? So we can at least stabilize the circulating fluid volume. And it is very important to administer this early on in order to maintain adequate blood flow to the organs, because if we are going to delay the administration of the fluids, well, think about the organ function. It will be degraded. The organs, the systems will be impaired. They will start to malfunction. Now, what else are we going to expect in the treatment of sepsis? We're going to have to administer the vasopressors in order to increase the systemic vascular resistance. Okay, the purpose for the vasopressors is to increase vascular resistance, to elevate the blood pressure. Okay, to increase BP. That's the main reason. All right. Another is the administration of antibiotics. This is big deal. Before you're going to administer the antibiotic to the patient, make sure that blood cultures have been obtained. Blood cultures. Maybe if the patient has wound infections, then we need to collect wound culture as well. So we will be able to identify properly the infecting microorganism. Again, make sure that there is collection of the blood culture, or if appropriate, if the patient has wounds, we need to obtain wound cultures, or maybe sputum culture as well. If the patient has respiratory infection, and maybe the microorganism is the real cause of the problem, so we need to collect these specimens. If appropriate, make sure that we've collected them before we administer the antibiotics. And the administration of the antibiotics should happen right away within the first hour of recognition of the infection. Okay, should be administered ASAP. Hello. You administer the antibiotics ASAP, because when we are administering the broad spectrum antibiotics, it can target the infectious source, and it can also reduce the burden of the pathogenic microorganism. Another thing that we're going to need to do in the sepsis is the administration of, or let's say the treatment of the infectious source. So what is this? We're going to need to maybe drain the wound, the infected tissue, or possibly have to have the patient undergo the surgery. But this is only going to happen if the patient is already stable. We want to make sure that the patient is stable first before we're going to have to send the patient to a surgical procedure. Okay, make sure you do that first. Now, another is the control of the blood sugar. Remember that there is hyperglycemia. Was there hyperglycemia? Yes, I believe so. Was there? If there is such hyperglycemia, there we go. The hyperglycemia, as a result to the compensatory mechanism by the body, especially in this patient, we need to make sure that the blood sugar is controlled, especially for those patients that have pre-existent diabetes mellitus. We need to address the hyperglycemia as well, because if it's not treated, it can also worsen the outcomes of our patient. So we need to tightly monitor their blood sugar. Now, in patients with the septic shock, The administration of corticosteroids will also be important, especially with a refractory hypotension. So we'll include here corticosteroids. So this is to treat refractory hypotension. If the patient is not responsive to the resuscitation of fluids, vasopressors, then corticosteroids can modulate the inflammatory response. Okay, as we know that the body has the chemical mediators, right? The leukotrienes, the bradykinin, the histamine, all these chemical mediators are actually the cause why there is vasodilation, okay, and also the decrease in the blood pressure and also leaking of the fluid from the vascular compartment to the interstitial spaces. So we are going to treat that as well with the corticosteroids to decrease the inflammatory response. Treats inflammatory response. Again, this is reserved to those patients that is not responsive, that are not responsive to the vasopressors, not responsive to the fluid resuscitation. So they're going to have the corticosteroids as an add-on to their treatment. Now, aside from these major treatments, guys, there's also a need for us to provide supportive measures while the patient is going to be in the ICU. Other interventions here will be to prevent stress ulcer. Prevent stress ulcer. What else? We're going to have to exercise thromboembolism prevention. So our patient will still need to have the leg squeezers. Are you familiar with the sequential compression device that will prevent the formation of the blood clots in the lower extremities? So those are very important to decrease the incidence of thromboembolism, or let's say the incidence of the DVT. All right, enough of this. Let me move forward to another screen. Let's talk about the next type of shock. Under the distributive shock, we have the anaphylactic type of shock, and this is a very common occurrence as well. This is caused by the exposure to the allergen that is causing severe reaction. And so our patient here will have a rapid onset of the anaphylaxis. So what are those manifestations? Well, yeah, I know you already are familiar with this one. So the patient will have the hives, the skin manifestations, the generalized, what do you call this, itching. And the patient will have that widespread redness in their skin all over the body. There's going to be skin flushing. They will feel the warmth, angioedema, which is basically the inflammation of possibly the oral surfaces, the tongue maybe. Yeah, that is an airway complication, right? And it can potentiate, or it can possibly lead to obstruction of the airway. So this is an airway symptom. Angioedema is a huge risk for the closure of the airway. What else? If there is going to be an obstruction of the airway, what can you list? What can you hear in the patient? Well, of course, that stridor, right? Especially when the air passes through a huge or a wider airway like the trachea, it can produce that stridor sound. It is high-pitched breathing sound, and the reason for that is the narrowing of the upper airway. Narrowing of the trachea. The larynx, yeah, let's just use trachea. Another is wheezing, especially. This is caused by the bronchospasm, narrowing of the bronchus, the bronchioles, where they are now starting to tighten up. So the airway is, the passageway is getting tighter. The air cannot pass through effectively those narrow passages. Now, what else? In a patient with an anaphylactic reaction, they're going to end up with vomiting, diarrhea. This is part of the body's response to the allergen, affecting the gut and also the motility and also the bowel function. That's why they're going to end up with a diarrhea. The patient will have tachycardia as well, and also hypotension because of the massive vasodilation. Remember about the shifting of the fluids from the vascular compartment into the interstitial space, and also the increasing permeability. So that is why our patient will be hypotensive. Don't forget about that rationale. Now, there's also signs of end organ hypoperfusion. So the patient will have decreased CVP, decreasing CVP because of the reduction in the pressure in the larger veins near the heart. What else? There's also decreased cardiac output and increased SVO2. Actually, this is decreased SVO2. That is decreased SVO2. So on top of the decreased central venous pressure, increasing heart rate, there's also increased or decreased cardiac output. So this is going to be much more varied for the cardiac output because of the changes in the amount of the blood that is being pumped by the heart. Remember about the shifting of the fluid from the vascular compartment into the interstitial space. And so it will be varied. Okay, now let's talk about the treatment, guys, of the anaphylaxis. We know that in a mild form anaphylaxis, we will be treating the patient with the antihistamines, right? For the mild, we're talking about anaphylaxis, so scratch that one. Anaphylaxis, we're going to treat this right away with epinephrine. Immediately, we're going to administer the IM, or let's say subcutaneous epinephrine, in order to reverse the closure of the airway. And also, we're going to have to expect that the medication can reduce the swelling of the airway, and also it can improve the blood pressure. So, what are the effects of the epinephrine? Remember, it can lead to what? Bronchodilation. That is why it is effective in treating anaphylaxis. And it can also improve the blood pressure because of the vasoconstriction, right? So the patient has low blood pressure. When we give them the epinephrine, it can cause the vasoconstriction. So it will stabilize their blood pressure. Now, there's also a need for us to give them fluid boluses in order to restore the circulating fluids or restore the circulating volume. We're going to have to give them the isotonic crystalloids. Again, our normal saline here, IVF bolus. Yes, get ready with that one in order to maintain adequate perfusion. And again, these are just the highlights that I'm giving you. So I hope that I'm done here. Oh, there's one more, neurogenic shock. I totally forgot. Another part of the distributive shock is the neurogenic shock. So what is this? This is going to occur whenever there is a disruption in the autonomic nervous system, especially causing it to have a vasodilation as well. There is vasodilation and hypotension. So what causes the neurogenic shock? Remember about the vehicular accident, head injury, spinal cord injury. Causes head injury, spinal cord injury. All right. This can lead to the vasodilation, massive vasodilation, I should say. All throughout the body, the blood pressure will be low. Okay. And again, it can lead to poor perfusion to the body organs. It can also cause a drop in the heart rate. There's going to be flushed, warm skin because of the vasodilation. Heart rate goes down. The central venous pressure will also go down. There is a drop in the cardiac output. Here in the SVO2, it will seem to be normal or probably increased because of the decreased utilization of the blood. Okay, so that's why there's not a lot of usage of the oxygen here because of the shifting in the fluids or the blood into the other portion of the body. Now, there's also going to be other etiology that need to be identified here. So what is this? There's going to be neurological deficits. So you might expect the following deficits. There's probably paralysis if there is an involvement in the spinal cord. Okay, so it will be dependent on what level. Again, in general, there's going to be paralysis if there is direct injury to the spinal cord. Now let's treat this patient. What do we need to do for this patient with the neurogenic shock? Well, one of the treatments here is to stabilize the function. And we're going to have to administer IV fluids as well to restore the circulating fluid. We're going to have to give them the isotonic crystalloids as well. We'll have to administer the vasopressors, the norepinephrine in order to cause a vasoconstriction. And to treat the bradycardia, expect to administer the atropine sulfate to boost the heart rate. Atropine for the bradycardia, vasopressors for the hypotension, and we also have the fluid resuscitation to replenish the circulation. Okay, so that's it. Let's tackle the first question. What time is it? Oh boy. Question number 1. Get ready. A 65-year-old male with a medical history of hypertension and type 2 diabetes mellitus presents to the ED with complaints of fever, generalized weakness, and reduced urine output over the past 24 hours. His family reports that he has been feeling increasingly unwell for the last 2 days, experiencing chills and sweating profusely. Based on the patient's presentation and clinical findings, the healthcare team considers the possibility of sepsis. The question now, in patients with suspected sepsis, what clinical findings suggest sepsis based on the diagnostic criteria? Select all that apply. Okay, get ready to answer the question. Again, the question here, in patients with suspected sepsis, what clinical findings suggest sepsis based on the diagnostic criteria? Select all that apply. So this is a general question. It's not pertaining just to the patient in the scenario. This is a general question about the criteria. So what are those items that you will pick here? Is it oral temperature of 101.5 degrees Fahrenheit or 38.6 degrees Celsius? Or B, hypoactive bowel sounds? C, urine output 45 mL per hour, heart rate of 98 beats per minute? E, systolic BP 112 mmHg? Or F, mean arterial pressure 64 mmHg? Mary answered A and F. AJ answered A, B, E. Identify. Remember about the criteria that I mentioned. So what are those items? Marie Flor answered A, C. Did you mean F? I'm seeing a letter T, so just maybe mistyped it. Okay, let's answer the following. ABF or Melrose. Okay, let's take a look into the items here. Let's see on letter A. Okay, oral temperature, which is 101.5 degrees Fahrenheit or 38.6 degrees Celsius. After? Okay. All righty. So take a look into the value. 38.6, 101.5 degrees Fahrenheit. The patient here has an elevated temperature, right? So anything above 100.9. Anything above 100.9 degrees or above 38.3, this is one of the criteria in identifying a systemic inflammatory response. SIRS, systemic inflammatory response. Right? That is one of the indicators or the criterion. So here in our patient with a sepsis, our patient will end up with releasing the cytokines, right? And all the other chemical mediators. So once these are going to be released in the bloodstream, these substances can also target the hypothalamus, and it will cause the elevation of the temperature. That is why our patient will end up with fever. Okay, so this is one of the answers. Let's tackle letter B. What is in letter B? Hypoactive bowel sounds. Did we say hypoactive bowel sounds earlier? No, we said something about absent bowel sounds. Okay, ileus. So this is going to be incorrect. Hypoactive bowel sounds make this statement wrong. We said something about ileus, absent bowel sounds. Let's take a look into letter C. What is in urine output of 45 mL per hour? Is it within the normal range or is it not? Okay, remember about the hourly urinary output in the adults. We're going to expect how much? At least 30 to 60 mL per hour. This is the range. Okay, so this is within the normal range. So this is another answer. What about heart rate of 98 beats per minute? Do you remember about that heart rate elevation as one of the criteria rather? Yeah, this is also correct. Anything above 90 BPM is actually part of the criteria. Heart rate of 98 is already elevated. So that's going to be one of the answers. Okay. What about here? Systolic blood pressure of 112 mmHg. Is there an issue with 112 mmHg? This is incorrect. The blood pressure here seems okay. However, if the person will have way less than that, then it could be an issue. Okay, so hypotension is a critical sign of severe sepsis, or let's say septic shock, but our value here is still within the normal range and it does not indicate hypotension. So we're not going to include this one. Not hypotensive. And take a look into the mean arterial pressure of 64. Yeah, that is low. 64, way below the lower limit of 70 mmHg. Normally, it should be greater than 70 mmHg. All right. Our patient is low, so suspecting that there is already shock. So let me consolidate the answers. This is a select all that apply question. We have letter A. We have letter... Urine output is... Actually, that's not part of it. So we are looking for clinical findings suggest sepsis. Okay, so we are going to pick oral temperature. What else? The mean arterial pressure, which is F, and letter D. Okay, let's not forget letter D. We are including the letter D here. So we have 3 correct answers in this test question. A, D, F. Okay. Why is C part of the answer? No, I made a mistake in marking that one. That is not part of the answer. So our answers are only A, D, F. The oral temperature of greater than oral temperature of 101.5. We also have letter D, heart rate of 98 beats per minute, and letter F, mean arterial pressure. Okay. All righty. So those are the correct answers. Now we'll talk about the mean arterial pressure. How are you supposed to calculate the mean arterial pressure? So guys, pay attention. We are going to talk about the mean arterial pressure this time. MAP. All right, remember about the normal value should be greater than 70, right? Above or equal to 70 mmHg. That is our expected value. Expected value for the MAP. So how are we going to calculate or determine the MAP of our patient based on the patient's blood pressure? So the MAP is calculated based on the systolic blood pressure, and we're going to have to add 2 to that one, and this is going to be multiplied by the diastolic blood pressure, and then we are going to divide that by 3. Okay, again, the mean arterial pressure formula is this: systolic blood pressure. You're going to have to multiply first the diastolic blood pressure by 2, and then you're going to have to divide it by the 3. Okay, so what are we going to do here? So let's substitute this one. So if in case the person may have a blood pressure of 120, same facility, 6 to 8 also accepted. Yeah, there might be some facilities that might accept the 68. It can vary from one hospital, but again, 68 is in the low end. It's not considered really sepsis yet, but this is the time that you need to keep an eye on your patient. Okay, so don't forget, guys, 70 is the cutoff, normal. If your patient is somewhere between 65 to 68, it's not really a sign of sepsis yet, but this is the time that you're going to be on your toes, that you need to monitor your patient much more frequently this time, because it can further go down. All right, review the literature in the evidence-based practice. This is not considered sepsis yet, 65 to 68. But this is the time, again, this is the time that you need to keep an eye on your patient. You gotta observe your patient more around this time if it's less than 70, okay? So let's proceed. If in case your patient's blood pressure is 120 over 80, diastolic of 80, systolic of 120. So how are we gonna do this? We are going to what? That is 120 systolic, okay? And then we're going to have to multiply the diastolic blood pressure by 2, okay? And then our constant, which is 3. So what is that? It's now 280 over 3. So when you are going to get the quotient here, we have the 93.3 mmHg. It's a simple calculation, guys. So just utilize the patient's systolic blood pressure, and then the patient's diastolic blood pressure will be multiplied by 2, and then you have your numerator divided by the 3, and this will yield your mean arterial pressure. Okay. Again, like I've said, in the literature, the accepted normal mean arterial pressure is 70 or greater than 70. If your patient is somewhere here, 65, 66, 67, 68, 69, they're not in sepsis yet, but you need to exercise more judgment here. You got to monitor your patient much more frequently, because it can possibly go downhill. So like I've said, it can, the what do you call this? The reference value of the MAP may vary slightly from one facility to the next. But again, the normally accepted value should be greater or equal to 70. All right? That is based on the evidence-based practice. All right. So I hope that you had understood the explanation. Who was that? Was that the Tiramaj? Okay. Let's talk about number 2. A client in shock develops central venous pressure of 2 mercury millimeter and mean arterial pressure of 60 mmHg. Which prescribed intervention would the nurse implement first? Is it A, increase the rate of oxygen flow, 2, or B, obtain arterial blood gas results, C, insert an indwelling urinary cath, or D, increase the rate of intravenous fluids? Question is, a client in shock develops a central venous pressure of 2 mmHg and mean arterial pressure of 60 mmHg. Which prescribed intervention would the nurse implement first? Is it A, increase the rate of oxygen flow, B, obtain arterial blood gas results, C, insert indwelling urinary cath, and D, increase the rate of intravenous fluids? I'm seeing D's. Okay. Letter D's. Adiola, James, Catherine, Mary. What about the rest? Ms. Flynn, Charity, Anita as well. Yeah, remember about that CVP value ranges from 5 to 10, in some books 8 to 12 cm water. And so with a value here that is 2, actually the cm water that is wrong. The unit of measure is wrong in this scenario. So I'm correcting that. 2 cm water, that is very low. It is indicating hypovolemia. And so what are we going to do here? We're going to have to what? Increase the IV fluid rate. We will do this because of decreased volume. Okay, the CVP value of 2 centimeter water. Okay, so we need to administer the IV fluids in order to restore the circulating fluid volume. Now let's take a look into letter A, increase the rate of flow. Is there a need for us to increase the oxygen concentration? Well, it is crucial as well. We can provide that to our patient only if the patient really has hypoxemia. We need to treat the hypovolemia first thing. So it is a circulation problem. Circulation issue. Fluid volume deficit. So this is the problem that we need to deal with this time. So look for that intervention that can address the low circulating fluid volume, which is the letter D. The oxygenation will address hypoxemia, okay, but not about the fluid circulation. So we are eliminating that one. Obtaining arterial blood gas. It is also important to check into the arterial blood gas, but it doesn't address the hypovolemia. Does not address hypovolemia. And letter C, inserting a Foley catheter. Yeah, this can be a secondary or maybe a necessary intervention only if there is a need for us to monitor exactly the urinary output and the kidney function, but it's not going to address the hypovolemia. It will only measure the urine output hourly, but not address the hypovolemia. So we are eliminating this one. Very good, guys. I'm seeing so many B's. Number 3, a client experiences an anaphylactic reaction following hydromorphone administration. The nurse should initiate which actions? Select all that apply. A, begin an IV infusion of D5 water and administer a 500 ml bolus. B, administer oxygen. C, briefly leave the client to contact the medical provider. D, document the event, interventions, and client's response. E, keep the client supine regardless of blood pressure readings. And letter F, rapidly assess the client's respiratory status. Again, the situation is on a patient developing anaphylactic reaction following hydromorphone. So what are the nursing actions that you should utilize for this patient? Are you going to do A, B, C, D, E, F? Which one? Okay, I'm seeing BDF from Mary. Administer oxygen, document the event, interventions, and client responses, and rapidly assess the client's respiratory status. Okay. What about the rest of you guys? What are your answers? So let me start eliminating those incorrect answers. FBD. Okay. FBD. All right. Let's start eliminating those other answers. Letter A. Begin an IV infusion of D5 water and administer 500 ml bolus of the D5 water. Will this resolve the issue? It probably not. It will not. Okay, why? The patient or the nurse should not be administering D5 water. Remember about the crystalloid, we're going to have to use the isotonic solution. Remember? So we're not going to administer anything with dextrose. It's not known to be used as the bolus for this patient. It is not an appropriate type of IV fluid. Dextrose is wrong. Always use NS or lactated ringers as prescribed. Okay? Only NS or lactated ringers. Now, we know that we really need to give bolus for this patient with an anaphylactic reaction, but we need to have the correct IV fluid. We need to give them the isotonic fluid. All right? The crystalloid. The D5 water that we have is not going to address the low blood pressure. Okay? It lacks the saline in it. Let's have letter B. Administer oxygen. Is oxygen part of the treatment, guys? Oxygen administration. What do you think? Yes, of course. We're going to have to administer the oxygen, especially that we are dealing with an anaphylaxis. And this can support the oxygenation, also perfusion. And we know that our patient will have the swelling in the airway, the bronchoconstriction, and so we definitely need to give him the oxygen as well to treat the hypoxemia. Okay, that's part of the treatment. What else? Briefly leave the patient to contact the medical provider. You're not supposed to leave the patient anytime when you encounter this problem. Do not leave the patient in the room. Okay, you have to watch the patient continually, or this time, because the anaphylaxis can progress really fast. They need to be monitored frequently in order to capture those worsening signs and symptoms. So if we're just going to leave them unattended, this can delay the detection of those life-threatening complications. So staying with the patient would be the answer here. What we can do is call or use the patient's call light maybe, or call bell, We can use the bedside telephone to call for a colleague or call the nurse station. Yeah, you can do that to get help from the other nurses. So no leaving the patient. We're not going to do that. What about letter D? Document the event, interventions, and client response. Yeah, that's given. It's a must that we are going to do that in order to facilitate sharing of the information with a care team as well. It will ensure a much more comprehensive record to the patient. And of course, the critical documentation is so important that it can help the continuity of care as well. Now let's talk about keep the client supine regardless of blood pressure readings. What do you think about that? Supine, really? Regardless of blood pressure readings? That seems kind of iffy to me. Well, the positioning for this patient should be based on the condition, not on this kind of statement. Regardless. That is a false word right there. Our patient should be appropriately positioned, especially if they are having anaphylaxis. So, if the patient is hypotensive, well, a supine position with the elevation of the legs can help improve the venous return. However, if the client is experiencing a respiratory distress, then you're not going to put the head down this time, okay? So here's the deal. If your patient is low with their blood pressure, with no respiratory issues, then you can do the elevation of the lower extremities. If no issue in respiratory function, no wheezing. However, if your patient has wheezing, then you don't have to do the head down. What you're going to do is make sure that the patient is sitting upright in order to facilitate breathing, okay? So keeping the patient supine regardless is a wrong treatment here. What about letter F? Rapidly assess the client's respiratory status. Of course, this can detect those adventitious sounds that can signify the patient has closure of the airway or narrowing of the airway. So we're going to pick that as well. So our answers this time are what? B, there is going to be D, and letter F. B, D, F. Let's take a look at number 4. Which of these patients who have arrived at the human immunodeficiency virus clinic should the nurse assess first? Is it A, patient whose rapid HIV antibody test is positive? B, patient whose latest CD4 plus count has dropped to 250 per microliter? And C, patient who has had 10 liquid stools in the last 24 hours? And D, patient who has nausea from prescribed antiretroviral drugs. It's a priority question, guys. Take your final pick. I'm seeing letter C, which is patient who has had 10 liquid stools in the last 24 hours. Wonderful. Yeah, that is the correct answer. A patient that is losing way too much fluids via diarrhea should be your answer here. 10 liquid stools in the last 24 hours. Yeah, the patient requires immediate assessment because of the risk of dehydration. And electrolyte imbalances. You're going to lose a lot of the potassium ions here, especially with the diarrhea. 10 times? Oh boy, that's a lot. And it can lead to the hypovolemic shock as well, if not managed well. Okay. If you answered letter A, patient whose rapid HIV antibody test, it's not really, it doesn't require an urgent need for assessment, but we can do that later, okay? We will be putting this patient of a less priority, Okay. Yeah, that's correct, Victoria. You're correct. So we are eliminating this. This is not urgent. Letter B, patient whose latest test of CD4 count has dropped to 250 per microliter. Yeah, that is a significant drop as well, but it will not require immediate assessment compared to the letter C. Eliminating that one. What about letter D? Patient who has nausea from prescribed antiretroviral drugs. This is an expected side effect. It can require monitoring, but not urgent assessment. Requires more monitoring, but doesn't require immediate assessment as of this time, okay? Does not require immediate assessment. So what we're looking for is that patient that has the most immediate symptom, okay, or the need, the urgency for a requirement to do a more of an investigation. We need to investigate further the manifestation. How many times? It's been 10, right? We need to do some more assessment here. So make sure that you follow through with this patient because they are at higher risk to developing dehydration and electrolyte imbalances, and also hypovolemic shock. Our answer here is letter C. Let's talk about number 5. The nurse is caring for a patient with extensive burn injuries and potential hypovolemia. Which assessment findings should concern the nurse the most? Is it A, urine output is 30 mL per hour, B, blood pressure is 90/40 mmHg, C, oral fluid intake is 100 mL over the past 8 hours, and D, prolonged skin tenting over the sternum. All right, take a look into the options here. The nurse is caring for a patient with extensive burn injuries and potential hypovolemia. Which assessment findings should concern the nurse the most? Is it A, urine output is 30 mL per hour, B, blood pressure of 90/40, C, oral fluid intake is 100 mL over the past 8 hours, and letter D, prolonged skin tenting over the sternum? Oh boy. Hypovolemia, don't forget. Don't get confused. What would you prioritize this time? And remember about the calculation? Try to calculate the MAP this time. What is the MAP in this patient? For the one, what's the blood pressure? 90/40. Calculate the MAP, guys. What is the MAP in this patient? I've given you the formula, so I want you to calculate the MAP. You remember that? Yeah. So you're getting 56 rounded off to 57, right? 56.67. Yeah. Anything below that, yeah, that is already hypovolemic shock, right? So the mean arterial pressure here is compromised. The body is no longer able to perfuse the body tissues. It's no longer safe. It's not able to supply oxygen. It's not able to supply blood to the tissues, right? So Look for that answer that can critically impair the overall function of our patient. Okay, letter A. What's in letter A? Urine output is 30 mLs per hour. It's within the normal range. So it's in the lower normal, so I will not be worried much about this patient. I will monitor this patient some more, but this will not call for an urgent. I will not select this answer for now, but I will keep an eye on this patient. Even though it says 30 mLs per hour, it looks normal, but I will keep monitoring this patient because it's borderline low. Okay, I will be concerned about this at a later time, but not the priority. So removing letter A, we're gonna pick blood pressure of 90/40 because of the MAP that is that low, 57. Oral fluid intake is 100 mLs over the 8 hours. I know it's significant. That is very low. Okay, there is inadequate oral intake, but it does not give us information on the current hemodynamic status. Okay, the reason that we are not picking this one is because it does not provide real-time information of current hemodynamics. Saying that it's over the past 8 hours, yeah, it's inclusive of prior hours. So it's not really the priority answer this time. It doesn't reflect the real-time hydration status of our patient, current hemodynamic status. Okay, your question, or please explain MAP. Okay, the MAP, which is the mean arterial pressure, is the formula that we're going to use in order to detect if our patient is able to maintain perfusion. Okay, as we know that the MAP should be at least equal or greater to 70 mmHg. So whenever the mean arterial pressure is less than 70, it simply means that there is now a compromise in the oxygenation, compromise in the blood supply to the body organs, the body tissues. There's already a compromise in the delivery of nutrients to the body tissues. Okay? And so if we are, like I've said earlier, if your patient is, let's say, 65 to 69, this is already considered low. And this is a time that you need to keep monitoring your patient because it can go down some more. But the patient with a sepsis, like I've said earlier, which is totally different, right? If we're going to consider about, like, say, 60, that is going to really impair the blood flow to the organs. So this is a time that we really need to intervene some more, okay? So again, MAP will give us idea of adequacy of tissue perfusion. So that's the simplest explanation of what an MAP means. But if is 90/56, as you said some time ago, can we neglect it as normal? 90/56, what is our calculation for that one? Let's calculate 90/56. So for the 90/56, again, the MAP is not just the sole indicator, okay? There are so many things else. But again, this is just one of the criteria. So 90/56, let's calculate that one. 56 is 2 times, oops, sorry. 56 times 2. Oops. Calculator is broken. 56 plus 90. divided by 3. So that's 67. Yeah, 67.3. So this time your patient is in that gray area. This is the time that you need to keep an eye on your patient. It's not considered hypovolemic shock yet, but your patient needs to be watched for, okay? I would not consider that as normal. I would consider this as a patient that would need more monitoring, because like I've said, our reference value will be equal or greater than 70 mmHg. I would not refer 67 as normal. I would just say, hey, I'm just gonna keep an eye on you this time, so we'll know for sure if it can go down some more later, okay? Can we pick C then? No, like I've said, C is not the real-time information about the hydration status, okay? Again, our patient's information on the hydration status of 100 mLs per hour does not reflect the real hemodynamic status. What we want is to know what is really going on in the circulation at the present time, which is basically the blood pressure that is 90/40, okay? We cannot pick letter C. Again, it's not a reliable indicator. Levophed, this time, no, there's no indication yet that we will be giving Levophed on this patient. Not quite yet. Remember about the resuscitation, we're going to start with the IV fluid bolus first with the normal saline solution. The Levophed can be given once our patient, okay, hang on a sec. What is our value here? 90/50. Possibly, if the patient is not responding to the IV fluid, then the Levophed will come next. All right? So that would be our next step. Yes, fluids first. And of course, this will accompany with the administration of the IV antibiotics if we have already collected the, what is this? Oh, we're not talking about sepsis in this situation, so we're not even gonna talk about antibiotics. So yeah. All right, so eliminate the antibiotics in this conversation. Alrighty, so take a look into the bolus first. Again, we need to resuscitate our patient this time. Let's proceed. Oh, letter D, prolonged skin tending over the sternum. So this is basically a lack of skin turgor, right? Decreased skin turgor. Whoops. Decreased skin turgor. Decreased elasticity. So our patient really requires more of hydration this time, but the patient with a prolonged skin testing can be an indicator much more of a chronic manifestation. Sometimes it's not a reliable indicator about acute issue in the hydration. Again, this is much more of a chronic indicator more than an acute issue. All right, let's move forward to number 6. Upon admission of a patient to the post-anesthesia care unit, the blood pressure is 124/70. 30 minutes later, the BP is 112/60 with a pulse. Yeah, it's a sign of dehydration. Old patient may have skin elastic problems. Yeah, so it's not going to be a definitive what do you call this, manifestations of the hypovolemia. It can accompany with the other manifestations, but not the sole manifestation. We're going to look for that manifestation that is actually a sign that there is severe hypovolemia. Okay, we need the value. We need to have that specific number. Okay. Number 6, upon admission of a patient to the PACU, the blood pressure is 124/70. 30 minutes later, the blood pressure is 112/60 with a pulse of 76 and warm, dry skin. What should the nurse do next? Is it A, increase the IV fluid rate, B, notify the anesthesia care provider, C, continue to take vital signs every 15 minutes, and D, administer oxygen therapy at 100 100% via mask. So this is a patient post-op with a drop in the blood pressure from 124/70 to 112/60. Again, guys, if you are doubtful of your answers, do the calculation of the map. If you're doubtful, do the calculation so you can figure out if it's really that significant. Okay. So I'm seeing letter A's, letter C. Okay. That's good. Let's remove our unnecessary options here. Let's start with letter D. Administer O2 100% via mask. Do we have any indication that our patient is low with a low oxygen? No. We don't see any information about low oxygenation, so we're not gonna worry about letter D this time. No hypoxemia. So we're not gonna worry about this administration. Now let's take a look into letter B. Notify the anesthesia care provider. Do we have to call the medical provider this time because of the drop in the blood pressure? No, we're not, because it's only intended to notify them if there is significant change in the blood pressure. Do you think that this is a significant change? 124 to 112? Not so much. Not a whole lot. The patient might have some form of hypotension around this time, and this could be as a result to the medications, could be pain medication, could be as a result to the anesthetic agents. So there will be some fluctuations, okay? This is expected in our post-operative patients, that there will be fluctuations within the normal range, okay? So that is not going to call for the notification of the anesthesia care provider, all right? We're only going to call the anesthesiologist whenever there is a significant change out of the norm. If the patient's MAP is affected, then we're going to call. And what is the MAP here? It's about 77, right? So I'm not going to even worry about the blood pressure. So we're going to eliminate that one. Calculating 112/60, that is basically around 77 MAP. Okay? MAP is 77. We're good. Okay, that is a normal expected fluctuation. Letter A, increase the IV fluid rate. What do you think about the IV? Do we need to increase that one? There's no worry, right? We're not going to worry about the blood pressure. Then why are we going to increase the IV fluid? There is no need this time, okay? There is no need to do that because we don't have a sign that there is already compromise in the perfusion. We're going to do the increase of the fluid rate when there is instability in the patient's blood pressure. Indicated when MAP is unstable or when the BP is unstable. So we don't have any other answers, but check on letter C. Continue to take the vital signs every 15 minutes. Go on, check your patient. Do more observations, all right? So our answer here is letter C. Guys, I hope that you're learning with the MAP today because this is going to be useful in your practice as future nurses. So make use of the MAP. It will really help you out. At least it will lessen your worries about your patient, less paranoid about, hey, what's going on with my patient? My patient's systolic blood pressure dropped. So make use of the MAP as well. All righty, let's tackle number 7. 6 hours after sustaining a thermal burn that covers 50% of their total body surface area, a patient weighing 90 kilograms is assessed by a nurse. Which finding should the nurse prioritize communicating to the healthcare provider? Is it A, blood pressure is 94/48 per arterial line? B, urine output of 42 ml over the past 2 hours? C, serous exudate is leaking from the burns? D, heart monitor shows sinus tachycardia of 106. What do you think about that? So you're answering letter B, urinary output of 42 mLs over the past 2 hours. So that's basically how many mLs per hour? That's 21. That is oliguria. That is significant, guys. That's only about 21 mLs per hour. This is a significant oliguria. It simply means that our patient is not getting enough perfusion to the kidneys. Decreased renal perfusion. Yeah, 21 mLs per hour. This one right here, what is the MAP in 94/48? That is about what? Yeah, low output. 48 plus 94 divided by 3. So this is about an MAP of 63, okay? MAP of 63. Our patient needs more monitoring. Need to call the medical provider for in case it will drop below the 60. Okay, so our concern here is about the blood flow to the kidneys. When the patient will have oliguria, it simply means that the body is not able to provide the needed blood. It will not be able to provide adequate oxygen. It will not be able to provide adequate nutrition to the kidneys. Our patient can possibly go into acute renal failure. This is the problem here, guys. All right. It doesn't immediately identify that the patient has shock. Okay, we're going to worry about the shock when the patient drops below 60. Okay, anything below 60 in the MAP, we're going to think about the shock. If your patient is somewhere between 61 to 69, keep monitoring the patient. It's on the low side, but keep monitoring the patient. Now, take a look into letter C. Serous exudate is leaking from the burns. What do you think about serous exudate? Is that expected? It is an expected finding in the immediate phase of the burn. And so what we're going to need to do here is to address the wound, but not going to require as immediate intervention compared to the patient's urinary output. This is expected. We're going to have to address this carefully, administration of the sterile dressing application, of course, because we don't want any contamination of the wound bed as well. But it doesn't really call much more critical nursing intervention compared to the letter B. Letter D, heart monitor shows sinus tachycardia of 106. Well, with a sympathetic nervous system stimulation during the acute phase, tachycardia is a common response to the burn injury. It's not really going to call for an immediate intervention unless if there is shock. Okay, at this point, there is no shock yet. Okay, so again, this is a typical physiologic response. We'll keep monitoring this patient's heart rate as well. All right, so we are going to answer the letter B. All right, how are you guys? Are you doing okay? Are you still there? Let's move on to number 8. After chest tube placement for a hemopneumothorax, the nurse monitors a patient in the ED. Which assessment finding should concern the nurse the most? Is it A, 450 mL of blood in the collection chamber? B, complaint of pain with each deep inspiration? C, subcutaneous emphysema at the insertion site? Or D, a large air leak in the water seal chamber? The question states, after chest tube placement for a hemopneumothorax, the nurse monitors a patient in the ED. Which assessment finding should the nurse be concerned about the most, I should say? Is it the 450 mL of blood in the collection chamber? Is it complaint of pain with each deep inspiration? Or is it subcutaneous emphysema at the insertion site? Or is it a large air leak in the water seal chamber? I'm seeing letter A. Okay. Remember about the concept in the placement of the chest tube and looking into the air leaks, the emphysema, those kind of stuff. Are they expected during the acute phase or not? So ask yourself about that one. All right, let's take a look into letter D. What's in letter D? A large air leak in the water seal chamber. And the scenario, guys, it's talking about a patient chest tube placement. After a chest tube placement, so this is quite a brand new chest tube in this patient, and the patient is still in an ED, right? So what do you think about a large air leak in the water seal chamber? Well, during the acute phase, an air leak is actually an expected finding in the water seal chamber, okay? In the acute phase, or right after, immediately after the insertion, an air leak is expected, okay? Air leak is expected. So that is the caveat, guys. Please don't forget this. If the patient just had an inserted thoracostomy tube, don't worry way too much if you'll see an air leak in the water seal. This is going to be an expected finding. However, if the patient is probably day 2, day 3 after the insertion of the thoracostomy tube, then we're going to worry about the air leak this time, all right? But during the acute phase, it is expected. We need to keep monitoring the water seal or the appliance itself, do some more assessment, okay? So we are going to eliminate letter D. What about letter C? Subcutaneous emphysema at the insertion site. What do you think about that subcutaneous emphysema? It can occur when the air leaks into the subcutaneous tissue, right? And around the chest tube insertion site. And it is also a known complication in the chest tube placement and would be a benign, and it would be self-limiting as well. And it doesn't really cause significant clinical complications, so it can resolve on its own. So we're going to have to eliminate letter C as well. Okay. Okay. Letter B. Chica Julius, you're so good. Complaint of pain with each inspiration, deep inspiration. What do you think about that? Of course, the patient just had an inserted tube, right? It is a painful procedure. This is an expected finding in our patient. We're going to have to deal with that patient with an analgesic, all right? Expected finding. So we're going to get rid of letter B. Our answer here is 450 ml of blood, which is basically a sign that there is an ongoing bleeding, okay? 450 ml is significant. There is active bleed. Guys, this is going to be your parameter. Anything above 250 mLs after the insertion is a sign of hemorrhage. Please take note of that. After the insertion of the chest tube, if the drainage exceeds 250 during the first 24-hour period, think about hemorrhage that is going on. There is an active bleeder in the patient's chest. Our answer here is letter A. Okay. So, to wrap this up, the air leak during the acute phase is an expected outcome. We need to keep monitoring the patient. Subcutaneous emphysema, this is also an expected finding, especially during an air leak. During the immediate phase, yes, we're going to keep monitoring this patient as well. All right, let's talk about number 9. In the CCU, a patient presents with restlessness and anxiety following an ST segment elevation. I just hit my microphone. So again, in the coronary care unit, a patient presents with restlessness and anxiety following an ST segment elevation MI. Vital signs reveal blood pressure of 84/38 and heart rate of 136 beats per minute. Given the assessment, which nursing diagnosis should the nurse prioritize for this patient? Is it A, decreased cardiac output related to impaired heart function? B, acute pain related to myocardial infarction? C, anxiety related to perceived threat of death? D, stress overload related to sudden health changes? What is your answer? Your patient is in CCU with restlessness, anxiety after an ST segment MI. The vital signs now has 84/38, heart rate of 136. What is your nursing diagnosis? Yeah. This is our favorite, right? In nursing school, nursing diagnosis, care plan. Guys, don't neglect the care plan. Actually, this will help with your next generation NCLEX. I know that they have not really. Have you seen more of that nursing diagnosis in the test items? Probably not. But I want to keep this in mind myself, that I should be presenting more of these nursing diagnoses, because it actually will guide you in planning, right? So I'm seeing letter A's. That's a good sign. It said decreased cardiac output related to impaired cardiac or impaired heart function. Yeah. STEMI, there is a risk of what? Cardiogenic shock. The cardiac output is going to be decreased in a patient post-STEMI. So, with the damage that has been done into the muscle tissue, it can severely impair the heart's ability to pump properly. And so, like I've said, it can lead to the decrease in the cardiac output and also unstable hemodynamic status. So this can lead to decreased BP and increased heart rate. All the more, it can lead into a vicious cycle. The patient will have a recurrence of BMI if we are not going to address this. Okay? So we need to control the patient's blood pressure and also the heart rate. So What about letter B? Acute pain related to myocardial infarction. We're going to address that when there is an emergent, we're going to address that right there and then when the patient's pain is present, okay? But according to the data, the blood pressure is already low, 136 with a heart rate. Yeah, that simply means the patient has the malfunction. The cardiac output is poor this time. I'm not going to even expound the other ones here. Okay. What is the MAP on this one, guys? I'm very curious. What is the MAP? 38 systolic. What do you think about that one? Plus 84. You divide it by 3. That is 53. That's compromised. So you need to deal with this patient. Make sure you're going to have to treat this patient in order to prevent any more hypovolemic shock, or cardiogenic shock rather, not hypovolemic, but cardiogenic shock. Let's tackle number 10. Following a change of shift report on 4 patients, which patient should the nurse assess first? Is it A, patient with dilated cardiomyopathy exhibiting bilateral lung crackles? Or B, patient with rheumatic fever experiencing sharp chest pain on deep breathing? C, patient with acute aortic regurgitation presenting with a blood pressure of 84/52? And D, patient with infective endocarditis displaying a murmur and splinter hemorrhages. Okay, 53 is the MAP. That's significantly low. Patient is in hypovolemic shock, Melrose. Yeah. Not hypo. Cardiogenic shock. I always get to think more of the hypovolemic shock because of all the scenarios that I've given. But yeah, cardiogenic shock. Your answer is what? Patient with infective endocarditis displaying a murmur and splinter hemorrhages. So you have 4 patients. So which of the following 4 patients that you should assess first, prioritizing the patient? Which one? Don't get distracted with the descriptions, right? With the words, don't get distracted. What about the others? Letter D, I'm seeing letter D. Letter B, no more C's? What happened? Okay. I'm seeing more of the C's this time. Okay. I really need you to be careful in answering this test question. Okay. So letter A, let's rationalize letter A. Patient with dilated cardiomyopathy exhibiting bilateral lung crackles. What do you think about the first option? Letter D. Okay. Cardiomyopathy, dilated cardiomyopathy. So what is this? The crackles in the dilated cardiomyopathy is basically letting us know that, of course, the fluid is accumulating into the lung tissue because of the possible heart failure exacerbation. Okay, possible heart failure exacerbation. But just basing into your assessment, bilateral lung crackles. This is expected manifestation in a patient with dilated cardiomyopathy. Okay, expected and will require monitoring. Okay, do you need to intervene on this patient right now? No. No immediate intervention yet. Okay, dilated cardiomyopathy, lung crackles. All right, we don't have any more manifestation. It can lead to pulmonary edema. Yes, it can. But with the limited information, do we have any more? No, we don't. So we will keep monitoring the patient. We will park this. Okay. What about letter B? Patient with rheumatic fever experiencing sharp chest pain on deep breathing. Is this assessment finding that is expected? Or is it something that would require immediate intervention? Okay. When the patient has rheumatic fever, when they're gonna take that deep breath, they will feel that pleuritic pain, which is an expected finding. Another expected finding, but does not indicate immediate instability. Okay. Does not need immediate action. Not yet. It is expected finding manifestation. Now let's take a look in letter D. Patient with infective endocarditis displaying a murmur and splinter hemorrhages. Did you pick this one? If you pick this one because you were worried about the hemorrhages, splinter hemorrhages, what do you mean by splinter hemorrhages? The splinter hemorrhages are actually those linear, very tiny hemorrhages under the nails. So these are what we call as splinter hemorrhages. All right, so this is expected in a patient with an infective endocarditis. They are going to look small, thin, red to reddish brown lines that will run in the direction of the nail growth. Okay, maybe you picked that one because of the word hemorrhages, but if we're talking about the hemorrhage, the degree of hemorrhage is very, very mild, like very tiny streaks of blood. So it's not even that significant. Okay, and so we are going to have to park this as well because the patient has a murmur, but we don't have any other manifestation. The murmur is an expected finding, but it doesn't really require immediate attention. Our patient that has acute aortic regurgitation with a blood pressure of 84/52, yeah, of course, right? What is our MAP here in our letter C? 52 plus 84 divided by 3. So our patient here will need much more of assessment because of the drop in the blood pressure. And again, acute aortic regurgitation. This is a brand new manifestation. We need to investigate further on this condition. Okay. The MAP is 62. Yeah, border low. We need to keep an eye. We need to investigate further. The question is, which patient should the nurse assess first? And of course, this is acute change in this patient. We need to deal with this one. Because if we're not going to assess this or prioritize this patient, we might be missing out so many more signs and symptoms associated with the low blood pressure. And this is already significant, guys. 62 is on the low end. any minute it could drop to 60 or maybe 58. So again, you will be on heightened alert on this patient, especially it's close to 60. All right, close to hypovolemic shock. All right, let's talk about 11. A patient admitted with a peptic ulcer has NG tube in place. Upon developing sudden severe upper abdominal pain, diaphoresis, and a firm abdomen, which action should the nurse prioritize? Is it A, check the vital signs, B, raise the foot of the bed, C, flush the nasogastric tube, D, administer the prescribed oral antacid? The question states, a patient admitted with a peptic ulcer has an NG tube in place. Upon developing sudden severe upper abdominal pain, diaphoresis, and a firm abdomen, which action should the nurse prioritize? Is it A, check the vital signs, B, raise the foot of the bed, C, flush the nasogastric tube, and D, administer the prescribed oral antacid? Take your pick. Okay. What do you think would be your best bet this time? Okay, I'm seeing A's from Mary and James. There's more A from Anita. Very good. All right, let's try to eliminate the distractor here, which is basically the letter D. Administer the prescribed oral antacid. Okay, your patient has peptic ulcer disease, but now the patient has a sudden severe abdominal pain, diaphoresis, firm abdomen. What is this? This is actually a sign of a possible perforation of a ulcer. Okay? Perforation, which can lead to what? Peritonitis. So if you are going to administer the prescribed oral antacid via nasogastric tube, yeah, it can introduce some more of the leak into the gastrointestinal contents into the peritoneal cavity. We are not going to do this. Do not administer oral or any medications or food or fluids into the nasogastric tube this time. Do not administer anything, including water, food, medications. Do not administer, because the patient possibly could have a perforated stomach, or it could be a perforated bowel. All right, we're not even going to flush the nasogastric tube, because if you're going to flush the nasogastric tube, the more that you are spreading leakage into the peritoneal cavity if there is perforation. No flushing. Okay, do not do any introduction of fluids, no more food, no more meds, nothing. It can worsen the peritonitis. Now, our battle here is between A and B. What do you think? Check the vital signs, raise the foot of the bed. Yeah, NPO would be our one of the nursing interventions. We're going to keep our patient NPO. That's a good call. All right. Very good. Love deep. NPO, make sure you do that. But between A and B, what are you going to do this time? You're left with the two options. If you are going to choose letter B, raise the foot of the bed, it can worsen the patient's condition because it can increase the intra-abdominal pressure. Can increase intra-abdominal pressure. Don't do this. Do not elevate the foot of the bed. Never. They will further cause leakage of the abdominal contents into the peritoneal cavity. No elevation. So we only have our answer here, which is letter A. Check the vital signs. And this is going to detect if there is what? Hypotension. That is the main answer. We're going to have to detect if there is going to be a drop in the blood pressure. Could be hypovolemic shock. Now, guys, there's diaphoresis. Firm abdomen. This is already a sign of peritonitis. Okay, firm abdomen. Yeah. So we're going to have to capture any signs of hypovolemic shock in this patient. Check the vital signs. Nothing else. Okay. And to add to that, we're going to have to keep the patient NPO. Do not elevate the leg part of the bed. No more flushing into the nasogastric tube. Keep the patient NPO. If the patient is in a lot of pain, if there is a PRN medication, IV, go ahead and give the medication IV for pain. All right. But make sure you notify the medical provider right away in order that you can obtain some more orders. Okay. Yeah, we always call to get some more orders. What's your order today, sir? Okay, let's move on to number 12. Based on the medical provider's prescription, which initial action should the nurse take for a patient who has vomited 1,100 mLs of blood? Yeah, prepare for surgery. That is a possible nursing intervention as well. Very good. Question number 12. Based on the medical provider's prescription, which initial action should the nurse take for a patient who has vomited 1,100 mLs of blood? Is it A, insert a nasogastric tube and connect the suction? B, administer famotidine 20 milligrams IV every 12 hours? C, draw blood for typing and cross-matching? D, give IV lactated ringer solution 1 liter bolus. Again, guys, I am reminding you to enroll into our NCLEX program. Our course is available for the entire 6 months. You can finish the course as early as 12 weeks if you're really going to spend more time in answering those test questions. And if you are quite faster with listening to the lectures, finishing those test items, then you can do some more of the NGN test questions plus the review materials that we have. So kindly check the website and also the description box below. I'm seeing letter D. Why letter D? I wish I could have done this lecture live, like in person, right? So I can talk to you, not just typing on the chat box. So what's your rationale for letter D? I want to know. But before that, we're going to have to eliminate those bad options first. What are the bad options? Letter A, insert a nasogastric tube and connect to suction. Yeah, the insertion of a nasogastric tube may be necessary later on for maybe a diagnostic procedure, but it's not going to treat the hemorrhage. Does not treat the hemorrhage. One liter, 1,100, that is quite a large volume. 1 liter of blood, that's scary, guys. I once admitted a patient, just brand new, like within 30 minutes after I received the patient from the emergency department, I settled him into his bed. And I was going to do the admission after I checked him, vital signs and assessment. And he asked if he could use the bathroom, right? And so I went and told him, yeah, you can use the bathroom, but I was still in the patient's room. And yeah, all of a sudden he called. He's actually pooping a large volume of black stools. Yeah, he had an upper GI bleed, a massive one. Yeah, to my surprise. So I immediately called the doctor. I don't know why it wasn't cleared in the ED, but yeah, that was the scenario. A GI bleed, my favorite case in med-surg. Okay, so I'm seeing letter D. So letter A, insert a nasogastric tube. It doesn't address the hemorrhage. It can be done at a later time for maybe a diagnostic procedure, but not this time. Letter B, administer famotidine 20 milligrams IV Q12 hours. This is what? A H2 receptor blocker or antagonist. H2 receptor antagonist. So it is an IV. Yeah, we can administer this one, but will it stop the bleeding right there and then? No, it will not. It is a part of treatment, but will not resolve or it will not replenish the circulating fluid volume. Not addressing active bleed. Okay, what about letter C? Draw blood for typing and cross-matching. Yes, we can do that as well, but is it as emergent intervention compared to the letter D? No, it isn't. We can do this after we had done letter D, which is give IV lactated ringer solution 1 liter bolus. This need to occur first because the patient has massive blood loss. Imagine 1,100. This can really cause the blood pressure to go down fast. We need to give the bolus right now. All right. The cross-matching can happen after we have dealt with letter D. All right. So eliminate, eliminate, eliminate. The cross-matching will be required when we are going to administer the patient with a blood products, packed red blood cells. Isotonic solution for a, for this patient. Okay. Now number 13, a patient presents to the ED with severe abdominal pain and rebound tenderness. Vital signs include temperature of 101.5, pulse rate of 124, respirations 30, blood pressure 80/52. Which prescribed intervention should the nurse prioritize? Is it A, administer a liter of lactated ringer solution over 30 minutes, B, arrange for abdominal computed tomography scan, C, give IV ketorolac IV milligrams for pain relief, and D, draw a blood sample for a complete blood count? D first, IV bolus to replace the fluid's blood loss. Yes, that's correct, Milrose. We need to do the IV fluid infusion for item number 12. Yes, I agree. Okay. Are you answering for number 13? I'm not quite sure. So, what is your answer for this item, number 13? Which prescribed intervention should the nurse provide? Your patient has severe abdominal pain, rebound tenderness, temperature of 101, blood pressure of 80/52, respirations 30. Yeah, abdominal pain, rebound tenderness, another case of peritonitis, right? And of course, the patient's blood pressure is 80/52. So let's eliminate those unnecessary options. Let's start with letter D. Draw a blood sample for a complete blood count. It is a good intervention, by the way. It is going to be helpful in assessing the patient's hematologic values. It is going to be very helpful, but will it address the immediate need for fluid resuscitation? No, it doesn't. Does not address fluid resuscitation. So we are going to eliminate letter D right away. Although it is a good intervention, but it does not address fluid resuscitation. What about letter C? Give IV ketorolac 15 milligrams for pain relief. It is a non-steroidal anti-inflammatory drug. It is going to be helpful. However, if your patient is in hypovolemic shock and, let's say, suspected of acute abdominal problem, the NSAIDs are not appropriate as they can worsen renal function. Okay? Not appropriate in hypovolemia. Especially that with the hypovolemia, there is going to be decreased renal perfusion. It will complicate the issue. The non-steroidal anti-inflammatory drug, together with the decreased perfusion to the kidneys, can lead to acute renal failure. So we are not supposed to administer ketorolac. It is an NS8. Do not administer this one. Look for another pain medication for this patient. Do not give this. Eliminate, eliminate. Letter B, arrange for abdominal computed tomography CT scan. It's also a good intervention, but it will not take precedence to our more critical intervention, which is basically administering 1 liter of LR bolus over 30 minutes. Okay, you gotta do this one. Our patient is in hypovolemic shock. Also could become septic, so we should administer the fluid bolus first things first, and we will be doing the rest of letter B and letter D once we have completed letter A. Okay, we're not going to give letter C. No ketorolac, no non-steroidal anti-inflammatory, because it will cause more impairment to the kidneys when there is hypovolemia. NSAID is never good to the kidneys. Let's talk about number 14. A 24-year-old woman arrives in the emergency department with a knife handle protruding from her abdomen. What should the nurse do during the initial assessment? Is it A, insert a urinary cath and assess for hematuria? B, remove the knife and assess the wound? C, evaluate for the presence of Robsing sign? And D, check for circulation and tissue perfusion. What will you do this time, guys? All right, let's take a look into letter A. Insert a urinary catheter and assess for hematuria. Do you think this is indicated for this patient with presence of the foreign body? A wound caused by the knife. What do you think? Insertion of a Foley catheter. Yeah, we can do the assessment of the hematuria, but it is not going to be the immediate priority in this scenario. No. All right. It's not about the insertion of a Foley catheter. This can take place after the completion of that important nursing intervention. So, less important. What about letter B? Remove the knife and assess the wound. Are you supposed to remove the knife? Never. You're not supposed to remove the knife because it should only be done in a controlled surgical setting. All right? Only done in controlled surgical setting. When the medical provider is around, when everything is set up, let's say minor surgical procedure in the emergency room department in trauma, then we gotta have to wait for the medical provider to do that, to removal. We're not gonna initiate removal of a foreign body. So our priority here is letter D, check for the circulation and tissue perfusion. Because of the injury possibly to the body organs in the stomach or in the patient's abdomen, we need to at least establish some kind of information regarding their blood pressure, their heart rate, their O2 saturation, so we will know for sure if there is massive bleeding going on. Okay? Now, what about letter C? Evaluate for the presence of Robsing sign. So what is the Robsing sign? This is an assessment that we can do to assess for appendicitis. Okay? It assesses appendicitis, which is basically not what It's not what we're worried about, okay? It's not relevant to the assessment and the management of the trauma. So our correct answer here is letter D. All right. Check for the circulation and tissue perfusion because of the bleeding that could happen in the abdominal cavity. All right. Now let's talk about number 15. So we're ready to 31 on my side. Number 15, which patient should the nurse prioritize for assessment first after receiving change of shift report? Is it A 65-year-old patient whose new ileostomy has drained 700 mL over the previous 9 hours? B, a 33-year-old patient who presents with abdominal distension and an apical rate of 130 beats per minute? And C, a 56-year-old patient with familial adenomatous polyposis who has occult blood in the stool? And D, a 42-year-old patient with ulcerative colitis who has had 6 liquid stools in the previous 4 hours. What is your answer for the last item? Number 15. Which patient should the nurse prioritize for assessment first after receiving change of shift report? James and Mary answered letter B. Okay, let's start eliminating. Let's take a look at letter D. A 42-year-old patient with ulcerative colitis who has had 6 liquid stools in the previous 4 hours. What do you think about this one? Is it a normal or expected finding? Or is this going to be a disease exacerbation? What do you think? Well, with this patient that has ulcerative colitis that had the 6 liquid stools in the past 4 hours, it simply means that the patient has exacerbation of his condition. Exacerbation. But this will require monitoring and also frequent checks on our patient, but is not life-threatening. Not life-threatening. Let's take a look at letter C. A 56-year-old patient with familial adenomatous polyposis who has an occult blood in the stool. Polyps, possible. It is an expected finding. It is actually suggesting GI bleed, okay? Occult blood, but it's not massive bleeding, right? Occult blood is that word right there. It is a serious condition, but will require evaluation. Requires evaluation. Maybe some more diagnostic test. But is this situation a life-threatening issue? No, it is not. Not life-threatening. Now let's take a look into letter A. A 64-year-old patient whose new ileostomy has drained 700 mL of over the previous 9 hours. What do you think about that? Large urine output. Yeah. New ileostomy, this is an expected finding, 700 mL. It will require assessment, but it is not life-threatening as well. We don't have any other choice, but actually letter B. Abdominal distension. What is this? This could be a sign that the patient has a perforation of an organ, abdominal organ. Could be a perforated bowel or the stomach. It can cause the peritonitis. The patient has already the tachycardia. Peritonitis caused by perforation of an abdominal organ. That is our priority, guys. Abdominal distension plus heart rate that is elevated. It is peritonitis or possibly intestinal obstruction. either or. This is life-threatening to our patient because when there is peritonitis, our patient can develop sepsis. Okay? Remember about the sepsis, it can cause the release of those chemical mediators, those substances that can cause widespread vasodilation. It can also cause increased permeability into the blood vessels. The patient will end up with massive hypotension and plus leakage of fluids into the interstitial spaces. This is life-threatening. So select letter B. All right? Abdominal distension and heart rate of 130 beats per minute. Okay, guys, I'm going to end the session this time. I thank you for your participation, and I hope that you had gained more information, knowledge, and of course, I'm hoping that your skill in rationalizing has improved. You're just doing it on your own, but I hope that you're able to critically think. This is very important in testing or in taking the NCLEX test. So again, I thank you for your active participation, and I hope I'll see you again tomorrow. We'll be talking a different system, and we'll be posting that thumbnail for you guys. So looking forward for a next topic with you, and you get to take care of yourself as well. Get some rest. You have a great evening or a good night or good afternoon. All right, bye-bye for now. You take care.